to primary failure of beta cells. No, this is secondary to the high cortisol. So unfortunately, Cushing's patients will have high sugar. And they're also going to gain a lot of weight. Makes sense. You're going to get hyperglycemia. That's going to increase insulin. Insulin causes growth. Okay, just like the poor babies. The poor babies, macrosomia in the babies, macrosomia in the adults too. All right, now notice the weight is going to be distributed kind of weirdly. You're going to get what's called truncal obesity. So notice, he's much more obese in the truncal area than compared to the arms. The arms will gain weight too, but the trunk gets it the most. They also tend to get round faces. Notice his face is kind of round, like a moon face. If you turn sideways, you'll often see a hump back here. We call it a buffalo hump. Yeah, weird distribution of fat. So it's this truncal or obesity. Now, what else they get? They get loss of the fast twitch type 2 muscle fibers. Remember, type 2 always atrophies first from disuse, but it also atrophies first here because we're actually going to break it down in gluconeogenesis. That's how much stimulation you have to make sugar. So you're going to decrease your muscle mass, especially in the proximal limbs, so you're going to be very weak. And because the muscle is being broken down to supply amino acids to do gluconeogenesis. Wow. So you're driving a high sugar state here. Now, cortisol also weakens collagen production. Collagen doesn't get produced properly. And sure enough, you get this abdominal stria. So you notice these purple, red stria? Look at these streaks here. They look like stretch marks, don't they? So you get these abdominal stria. You get very easy bruising and very thin skin. So cortisol is anti-collagen. What else? It also increases androgen, so you tend to have a hirsutism, get very hairy. And of course you can have menstrual anomalies as well from high androgen. And then finally, you also have increased risk of infection. Risk of infection increases, especially when it's high sugar. High sugar, your immune system, they don't work properly. You glycosylate the adhesion molecules, cells don't migrate properly. Also, it affects phagocytosis too. All right, now here are the classic clinical features and the percentage of people who are going to have them. So they're pretty much almost always obese. They tend to have a facial redness and swelling, and a round face as well. Loss of libido, thin skin, very thin skin. Decrease in linear bone growth, so they tend to be short. They get it because they have this as a child. Menstrual irregularities, diastolic hypertension. We haven't talked about that, but that's pretty important, diastolic hypertension. Hirsutism, growing hair like crazy, emotionally liable, bruising. Glucose intolerance is a biggie here. And of course, this is very important. Most obese patients are not going to have osteoporosis because obese patients have a lot of estrogen from aromatase activity. So this is the only time you're ever going to see a patient be obese and get osteoporosis and fracture. Now, obese patients usually have problems with the joints. They have no problem with the bones because of all the weight bearing and the estrogen. So obese patients usually have joint problems. So this is kind of weird. Obese patient with osteopenia and fracture usually all over Cushing's. Only time you see obesity with osteoporosis. Cool. So lots of interesting features to notice here. Now look at this woman before Cushing's and after Cushing's. Notice the rounding of the face. That's what they call the moon face. Doesn't she look really puffy? That's what happens when you put people on prednisone. Put them on prednisone, they get all puffy like this. Very classic. Moon face. Look at the abdominal stria. The stria, purple stria. Collagen. And notice the truncal obesity, much worse than the arms. The arms are obese too, but trunk is worse. Kind of hard to see here, but back here, she's got a little bit of a bump here. This is going to be that buffalo hump that they talk about, buffalo hump. All right, now, let's get to the money. As a clinician, you can't just say, okay, diagnosis Cushing's, pay me. You've got to find out why they have this Cushing's. What is the cause of it so we can treat it and reverse it and go back to normal? So you're going to recognize the truncal obesity, the hypertension, the high sugar. So how do I confirm that they definitely have high cortisol? Well, you can't measure cortisol once because it fluctuates throughout the day. So what we like to do is measure 24-hour collection of urine-free cortisol concentration. If this is high, you confirm the diagnosis. So again, how do I diagnose Cushing's? Cortisol, 24-hour urinary, 24 urinary cortisol. That's how you're going to confirm the diagnosis is Cushing's. Now we have to find out why. Why do you have it? Well, on Earth, the most common cause of Cushing's is us. It's doctors giving you prednisone. So most common cause is iatrogenic, doctor-induced. We're giving exogenous cortisol to the patient. Exogenous. Now, we know we're doing it. We know we're doing it. So it's not going to be a diagnostic dilemma. They're going to say the patient's taking cortisol, and of course they're getting blue face, buffalo humps, because of the Cushing's you're going to cause by being on long-term prednisone. So we don't want to keep you, we want to do courses of prednisone. We don't want to keep you on a long-term because of the Cushingoid effect. Now, just tell me, if you're taking cortisol, gives negative feedback on the pituitary. So what's the ACTH going to be? Well, ACTH level is going to be really low here. It's going to be really low because we gave you high cortisol. So ACTH is going to be really low. So what happens to the poor adrenal glands? Look at how small they are. They're tiny. So tiny. Now again, just the cortex, not the medulla, the medulla will be fine, but the cortex is going to atrophy. Which layers? Well, the biggest layer is the fasciculata. So fasciculata and also the reticularis are going to atrophy. Those are the two layers that are the most atrophy, especially the fasciculata, because it's the majority of the cortex. So they're going to be really small and shrunken cortexes. All right, now tell me, what if you just stop the cortisol suddenly? So patient was taking it and then they stopped taking it. No, you always taper steroids. You taper it because if you stop the steroids suddenly, well, you go into acute adrenal crisis because these adrenal glands have basically atrophied. They have undergone atrophy. So if you suddenly stop the cortisol, the chronic cortisol, they're not ready to work. You go into adrenal crisis. So very important that we taper steroids to allow this atrophy to reverse back to normal. So we taper it to allow the adrenal glands to start upregulating again. All right, that's very important. I'm going to just draw a line here because that is not going to be a diagnostic issue. What's going to be an issue is endogenous production of cortisol by your body at high levels. Now, this can be due to a pituitary tumor. We call it pituitary Cushing's, and notice it is the most common cause. So you see Cushing's, always think about pituitary Cushing's. Since it's the most common cause, they can change the name. They call it Cushing's disease. Yeah, Dr. Cushing discovered the adenoma was producing too much ACTH. So they call it Cushing's disease only when it's due to the pituitary tumor. Now, a second cause could be the adrenal gland. The adrenal gland causing it, or it could be ectopic, a tumor. Ectopic tumor is about 10% of cases. An ectopic tumor producing ACTH. Now, let's go through them and distinguish the three causes. Is it ectopic tumor? Is it adrenal? Or is it a pituitary tumor? Okay, pituitary is most common, so we'll do that first. If there's a pituitary adenoma, it's making high levels of ACTH. High levels of ACTH. It's going to be sky high. No doubt about that. That's going to stimulate the adrenal glands to become huge. Hyperplasia of the adrenal glands, and that's what's going to make all this cortisol. That's what's going to make all this cortisol. Yeah, so the pituitary is stimulating the glands to work. You gotta work. You make a lot of cortisol. Okay, so high ACTH, high cortisol. Now, what about if it's an adrenal tumor? If it's an adrenal adenoma, so a tumor of the cortex, or the fasciculata layer, has become an adenoma, well, that adenoma is going to make too much cortisol because that's what the fasciculata makes. So when it becomes a tumor, it's going to make too much cortisol. All right, now that's going to give negative feedback on the pituitary. So what's ACTH level going to be? Low. So right away, how do I tell a pituitary tumor from an adrenal tumor? Very easy to tell these apart. Very easy to tell these two apart. Look at the ACTH level. Easy to tell them apart. Now, what can be an issue is if you have a topic production of ACTH. So maybe it's a bronchogenic lung cancer like small cell, maybe it's renal cell carcinoma, because they can make anything. If these tumors are making ACTH, well, ACTH is going to be high. Now again, any problems distinguishing these two? No problems. No problems, it's easy to. The problem is here. This one versus this one. That's going to be your issue. Now notice, when the tumor is making ACTH, the adrenals will also undergo hyperplasia. So these are very similar, very similar. Of course, the hyperplasia will make the cortisol increase. So we got to tell them, a pituitary Cushing's will make topic Cushing's, because that can be an issue. They're both going to have high ACTH. So the way to distinguish them, we have to do another test called the dexamethasone suppression test. Dexamethasone suppression test. We're going to try to suppress the cortisol production by giving dexamethasone. That's what we're going to try to do. Now, here's the rule. Dexamethasone test never suppresses any of these. It never works unless you do high dose. So let's repeat. Low dose never works for any of them. The only time it works is high dose, and the only time it actually works is if it's a pituitary tumor. Pituitary tumors will respond and you'll suppress. It's the only time it ever suppresses. So let me repeat, dexamethasone never works. If it ever suppresses, immediately get an MRI of the pituitary. It's a pituitary, I know, it's Cushing's disease. So that's the only time it ever suppresses. Because think about this. Is a bronchogenic lung cancer, a small cell, going to listen to high levels of cortisol analogs? Is that going to give negative feedback? Small cell is like, screw you, I'm just malignant. Renal cell is like, I don't listen to anybody, I'm a tumor. It ain't going to listen. It's never going to be able to suppress a tumor. These tumors don't listen. Now, how about an adrenal tumor? Well, adrenal tumors respond to ACTH. They don't respond to cortisol analogs. So it's never going to suppress this either. But the pituitary is supposed to get negative feedback from cortisol and cortisol analogs. So it makes sense that the pituitary tumor is the only one that will actually respond and suppress, because pituitary is supposed to get negatively inhibited by cortisol and cortisol analogs. Makes sense, but it only works with high dose. Only if you give high doses because it is a tumor. It's an adenoma, it's benign, but it only responds with high doses. So again, it makes sense. It makes sense that dexamethasone, which is an analog of cortisol, would give negative feedback on a pituitary tumor. Makes sense. All right, now, deep breath. Only one with the universe, nothing else matters. How many tests are there here? 3. 3 tests are all you need to know, and you'll rock step 1, step 2, step 3, you'll rock the wards, your endocrinologist will think you're amazing. There's 3 tests. Number 1, how do we know it's Cushing's in the first place? 24-hour urine-free cortisol. That's the way you're going to diagnose it. Okay. Number 2, how do I know etiology? Well, 2 tests. Get the ACTH level, because ACTH will definitely tell an adrenal tumor from the other 2. We'll definitely separate that. But if it's high ACTH, I have to do another test called the dexamethasone suppression test. If it suppresses, it's pituitary. Get an MRI of the pituitary gland. If it doesn't suppress, no suppression with dexamethasone, then you better get a CT of the chest for lung cancer and a CT of the abdomen to look for a renal cell. Make sense? So that suppression test tells me where to look. Where should I look? Now again, if ACTH is low, we know it's the adrenal. Now just for fun, what is the adrenal going to look like when you do a CT? Well, what you're going to see when the adrenal gland has a tumor, you're going to see one gland is big. Why? Because it's got a big old tumor. One gland is big because it's got a tumor in it, so there's the tumor. Now, what's the other gland going to be if this tumor is making all the cortisol? It's doing all the work. Well, the other gland is going to be really atrophic. It's going to be really small. So one big one with a tumor and one small one. Because of negative feedback, it's atrophying. That's so cool. One big one, one small one. That's an adrenal tumor. an adrenocortical tumor. Okay, makes sense? So again, I know what tests to do next. And notice, when I talk about endocrine, never start with radiology. Never start with radiology. Don't do an MRI of the pituitary as your first test. No, we want evidence, biochemical evidence. We want to look in the blood. Look in the blood first. Same thing here. We want to look at the cortisol first. We want to look at the ACTH first. We want to do dexamethasone suppression tests. If something's hyperfunctioning, you try to suppress it. Make sense? Then the last thing we ever do is radiology. Because again, if you do an MRI of everybody's pituitary, you might see some nodules from time to time and nothing. You did CTs of adrenal glands, you're definitely going to see nodules. There's always nodules in people's adrenal glands, which is normal. So you only want to do it if you already have biochemistry issues telling me, hey, there's something wrong there. Okay, so very important to do radiology for imaging only at the end. Once you know there's a tumor, then to just radiology fine. Okay? All right, so again, 3 tests. Prove it's Cushing's by getting cortisol, urinary 24-hour, then do ACTH and dexamethasone suppression tests, and that should separate them easily. Trust me, there's going to be questions on this. On my exams, and there's going to be questions on this at USMLE, because they love these up arrow, down arrow, suppression tests. They love this kind of stuff. All right, I think you guys got it. Now, let's talk about primary hyperaldosteronism. So we talked about too much sugar. Now we're going to talk about too much salt, too much aldosterone. So primary means a gland. The gland is making too much aldosterone. So for primary, it's the gland. The gland is doing it on its own. Why would the gland autonomously overproduce aldosterone? Because aldosterone, well, that's going to hold on to salt water. Your blood pressure is going to go up, and that's going to suppress renin. Renin's going to be suppressed because this is going to produce hypertension by itself. So let's repeat, high aldosterone produces hypertension. So therefore, renin, you don't need renin anymore, you're going to get high blood pressure. So renin gets negatively inhibited, and plasma renin will drop down. So again, how do we know it's primary? Check renin. How do we know it's primary? Well, you got high aldosterone, but check the renin. If renin is low, if it's secondary, it'll be secondary to renin. Renin will be high. So if renin is high, then the aldosterone is being secreted because renin angiotensin is telling it to secrete it. That would be a secondary case. So this is primary, the gland producing it by itself. Okay, now why would the gland do that? Well, number one, the most common cause is bilateral idiopathic hyperaldosteronism. It's the most common cause. 60% of all cases are due to this. What will you see? You'll see bilateral nodular hyperplasia. So it's like a hyperplasia of the adrenal. It just starts making too much aldosterone. But that's not sexy and testable for boards. It's the most common cause, but they want a tumor. They want a tumor. So let's talk about the adrenal cortical tumors, neoplasms. Now let's repeat. We just saw a cortical adenoma making cortisol that led to Cushing's. Now we can have adrenal cortical tumor producing lots of aldosterone. So aldosterone producing adenomas account for about 35% of all cases of hyperaldosteronism. And they give it a fancy name. They call it Conn syndrome. Conn's. Yeah, this usually occurs in adults, usually females twice as much as male. They call it Conn syndrome. So we're going to talk more about this one because this is an important cause. We'll talk more about it in a second. Now, the last cause is you can have genetics. Genetics. You can have familial hyperaldosteronism. It's a small percentage of cases, pretty uncommon, but it's a mutation in the gene leading to overactivity of aldosterone synthase. Okay, makes sense. If you mutate the gene, you produce more aldosterone just genetically. You're going to have high aldosterone, you're going to have hypertension. Genetic hypertension. Genetic one. But pretty uncommon, and I doubt if they'd ask it. So again, low yield, high yield. So only focus, I don't want to memorize everything. I want to focus on, hey, what are they going to ask me? What do I really need to know? And that's Conn's. So let's talk about Conn syndrome. By the way, you guys are too young. Do you remember Star Trek? Do you remember the original, the movies, the original movies, the second movie, Star Trek, The Wrath of Khan? Yeah. So Captain Kirk, your adrenal adenoma is making too much aldosterone. Con. You don't know that movie. You're too young to know it. You're too young. You've seen the remakes. But if you ever get a chance, watch the second Star Trek movie ever made. It's pretty awesome. Wrath of Khan. Ricardo Montalban. Good acting. Alright, very cheesy though, but still good. Now let's go to Conn syndrome. Let's talk about it. It's adrenal cortical tumor making aldosterone. Now just for fun, look at this picture. Do you see it? How do I know this is a tumor? Here's the adrenal, nice cortex, nice medulla, nice red-brown dusky medulla. How do I know this is a tumor of the cortex? Because it's bright yellow. If you see a yellow tumor, that is a cortical tumor. If it was a tumor of the medulla, it would be dusky tan red, red tan. So it'll be a red tan, be dark colored. It's like a pheochromocytoma, which comes from the adrenal medulla. It'll be the color of the adrenal medulla. This is the color yellow. This is the color of the cortex. Now, I want you to remember this picture because I can use this picture for 3 diseases. If this tumor, it's a cortical tumor, if it's making cortisol, you'll get Cushing's. If it's making cortisol, you get Cushing. Cortisol, you get Cushing's. If it's making aldosterone, you'll get Conn's. And then finally, if it's making 17 keto steroids, those are your sex hormones, well, then you're going to get virilized. These androgens are going to virilize you. So we call it the adrenal genital syndrome. Adrenal disease where your genitals get virilized. So again, they love this picture because I can use a cortisol making Cushing's, aldosterone, Conn's, and 17 keto sex hormones. That'll give you the adrenal genital syndrome, which we'll be seeing in a few pages. We'll see that in a few pages. So this picture, very popular. Now again, we're going to talk about aldosterone now, and in a few minutes we'll talk about making sex hormones. All right, now high aldosterone, that's going to give you hypertension because it's going to hold on to salt and water. So what happens to your blood pressure? High. Well, what happens to your sodium? High. That's the reason. So high sodium and high water. You're retaining sodium and water, you get hypertension. Now, what does aldosterone do in the kidney to your potassium? It wastes it. Renal potassium wasted. So potassium's going to be low, and that's often how they present. They're going to have hypertension, but they don't come in with it that often. You may find it incidentally, but they're going to come in with the hypokalemia, which gives weakness. That's usually how they present. I'm so weak. I'm getting numbness, paresthesia. I'm getting some visual disturbances. That's the most common presenting finding is weakness. So at diagnosis, they're always weak with hypertension. So in my brain, here's what I remember. Whenever I see hypertension with hypokalemia, immediately think high aldosteronism. Think of Conn syndrome right away. Forgive it right away. So again, hypertension with hypokalemia, very important clue. Now, how do I know it's primary? It's the adrenal gland? Well, check the renin. Because you got high blood pressure, you get negative feedback, and renin will be low. So low renin. And that's often what they ask in the exam. They ask, there's a tumor in the adrenal cortex, the blood pressure's high, the potassium's low, what's the renin going to be? It's going to be low. This tumor is making aldosterone, because you got high blood pressure and hypokalemia. All right, now under the microscope, if we take a look at the tumor cells, notice I'm not showing you a picture of the microscope for a reason. And it's really hard to tell if endocrine tumors are benign or malignant under the microscope. Really hard to tell. You really have to look for evidence of metastasis or evidence of aphasia. But there is a good, interesting feature here. You tend to have what's called these spironolactone bodies. So that's kind of like a buzzword. An adrenal tumor with spironolactone bodies, so adrenal cortical tumor with spironolactone bodies. Yeah, these are going to be pink. They're laminated cytoplasmic inclusions. These are very characteristic finding in Conn syndrome. Okay, now again, once I have this biochemistry evidence that it's probably hyperaldosteronism, I'm going to get a CT of the adrenal. But I don't start with it. I get one, and I'll see the tumor. Now the way you're going to take it out is you do laparoscopic adrenalectomy, or if you don't want to do the adrenal, you not surgically a candidate, maybe they already lost an adrenal, maybe that's an accident or something, then you can do long-term anti-mineralocorticoid therapy. So if you make it too much aldosterone, I'll inhibit it. So you can give things like spironolactone or eplerenone, however you say that name. These are anti-mineralocorticoids. All right, now what's very important is if I do remove this tumor, your hypertension should go away. So this is one of the rare surgically correctable forms of hypertension. This and a pheo. These are two classic cases where if I remove the tumor, you're going to go away. Hypertension should go back to normal. That's pretty cool. Surgically correctable hypertension. Another form of hypertension would be renal artery stenosis. I can go in there and stent it. If I stent that, well, then the renal vascular hypertension should go up. So whenever you have a chance to cure hypertension, that's pretty impressive. Because most hypertension is multifactorial. It's your genes and your diet and your lifestyle and like a million different factors. Here we can actually cure some of these surgically, and that's always cool. All right, there's con. Let's talk about secondary. Why would you get aldosterone produced from your adrenal cortex? Well, if you have high renin. High renin will secondarily tell the adrenal gland through angiotensin to produce aldosterone. So that's why we call it secondary. So it's aldosterone released because of activation of the renin angiotensin. So this is the one that's going to have high renin, high angiotensin, and high aldosterone. Now, what's going to increase my renin? Well, anything that lowers your blood pressure, right? So is no perfusion, like renal artery stenosis. Maybe you got renal artery stenosis from atherosclerosis. Maybe you got arteriolar, they call this hyaline arteriolosclerosis. When it's a kidney, you call it nephrosclerosis. So hyaline arteriolosclerosis, narrowing down of blood flow. What about if there's hypovolemia? Hypovolemia, it's just not volume. Well, then you get low blood pressure and your renin will go up. So maybe you have edema, you get heart failure, cirrhosis, any of these things where fluid leaves the vessels, well, I get low blood pressure. And then finally, pregnancy. Estrogen induces or increases plasma renin. Makes sense. Remember, pregnant women are usually a lot of volume, right? And they tend to have lower blood pressures, but we want to bring the blood pressure back up. So estrogen induces renin, renin brings the blood pressure back up. Okay, so some pregnant women can get really high blood pressure. And that's always dangerous if the blood pressure is too high. Right? We want to bring it up, but not too high. So very important, pregnancy and renin can go up and get hypertension during pregnancy. You can also get preeclampsia too. All right, now let's talk about hyperfunction of the sex hormones. Now, obviously, if an adrenal makes too much androgen, sex hormones, you're going to get virilized. So adrenal genital syndromes. Now, in a boy, if you have lots of androgens, well, you just be big. If you be very manly, you get maybe precocious puberty. But if you're a girl and there's too many androgens, she'll get virilized, and that's not cool. So this is any adrenal cortical problem where you secrete one of these two compounds, because they can be converted to testosterone, either dihydroepiandrosterone or just androstenedione. So both of these can be converted to testosterone and they can virilize. Now remember, ACTH normally regulates two layers, the sugar and the sex. So ACTH is supposed to regulate it. Now, adrenal causes of androgen excess, which give us this adrenal genital syndrome, are things like adrenal cortical tumors, tumors in the cortex. They're going to make you virilize for sure. Now, what's interesting here is most of the time they're adenoma. We've been saying adenoma for this, adenoma. This is usually due to carcinomas. Again, under the microscope, I can't tell. I tell because it's invasive, and I tell because it metastasizes. That's an adrenal carcinoma. So that's not such a good thing to have a carcinoma and be virilized. I'm virilized because of a carcinoma? No, that's not cool. A girl gets virilized and she has a metastatic tumor, not a good thing. So that's one thing that can do it, adrenal cortical tumor. But the one we really like in exam is if the baby has an enzyme problem, a genetic enzyme problem. We call it congenital adrenal hyperplasia. And you remember these from biochemistry. Biochemists get so excited, they showed you the pathway with all the blockages. Do you remember all those blockages, that pathway? I can still see that picture in my brain, but it's so fuzzy. It's so fuzzy. Because I memorize it gone, memorize it gone. I memorized it once for biochem, I memorized it again for physio, I forgot it again then. Then they came up with a path again, I forgot it 3 times. So I want to kind of get it in my brain, but I don't have any brain cells. So I'm going to do it the easy way. Congenital adrenal hyperplasia is due to a group of recessive metabolic errors. Most commonly, it's due to 21 hydroxylase deficiency. So there's 3 enzymes. 21 is the most common. We also have 17, and we also have 11. These are the 3 common enzyme deficiencies. So I want to make sure I know every feature of these without memorizing. So a quick and easy way is just look at the numbers. The second number tells you what happens to the sex of the patient. So take a look. These are not lollipops. I'm not 50 Cent. I'm not taking you to the candy shop. No, this is clinomegaly. So if you're a girl and you have 21 or 11, you will get the adrenal genital syndrome. You will become virilized. So notice, most cases are going to be 21, but 11 can do it as well. Notice 17 is not here. It's not here because 17 is not going to give you virilization. I'll show you why in a minute. Okay, but these excessive androgens are going to cause clitoral hyperplasia. Hey girls, do you have this? I got this thing here. Do you have this too? And also, if they're in utero as a baby, you can get pseudohermaphroditism. Yeah, because it can look like you have a micropenis. And clitoral hyperplasia gets really severe. All right, so that's not a cool thing to have. Now, what about the first number? The first number tells us what happens to the blood pressure. So always remember, this is a 1, this is a 1. They're like up arrow for hypertension and hypertension. So these 2 get hypertension. A 2 is written like this. A 2 is like you're going down. A 2 gives you low blood pressure. You get hypotension. So I never miss it. I just remember the numbers. So 21 is low blood pressure and girls get virilized. Boys, you'll just be big. 17, hypertension, but girls don't get virilized. And then 11, you get hypertension and girls get virilized. Makes sense? So 21 and 11, those are the 2 get virilized. By the way, I think they stole this and put this in first aid now. Now that I've been saying it for years, they put it in first aid. But this is good. I want to make it awesome. I want to go back to that darn picture with the blocks, and I actually want to remember it. I want to remember just a little bit more detail. So let me switch over, and I cross my fingers that it doesn't ruin everything. Let's see. Is it going to behave? Let's see. Oh no, already a bad sign. I have a clock. Not good. Oh, come on. Ooh. All right, so I can stay on this one. No. Yes, it stays. Okay, good. All right, so at least if I can find a blank here somewhere, maybe towards the end. Look for a blank. Oh, good. Here's a blank. No, it's not blank. It's not a blank. Looking for a blank. It's just slow. Here's one. Okay, here's what we'll do. Let's do this in greater detail. And this is going to work really good. It'll work on your biochem exams, it'll work on your physio exams, it'll work on the USMLE. Okay, where do all of the hormones come from? Well, they all come from cholesterol. We start with cholesterol. That is our basic building block for making hormones and steroids. Uh-oh. Okay, there we go. So we start with cholesterol. Now, cholesterol is going to become pregnant. Pregnenolone. This is where everything is going to come from. This is pregnant with the 3 hormones. Remember, GFR, right? It's going to give us our G and our F and our R. It's going to give us GFR. Now, glomerulosa was making our aldosterone. Fascicularis was making our cortisol. And reticularis was making our sex hormones. Okay? So aldosterone, cortisol, sex hormones, which are the 17 keto steroids, right? And let me just put this up here. We had 21, we had 17, and we have 11. That's the short way, the easy cheating way of doing it based on the blood pressure and whether you get virilized. But I just want to do this a little better. Now I want you to notice, we have 2 1s and a 7. Do you see that? 2 1s and a 7? So let's write that. 1, 1, 7. Is that not a 1, and a 7? Yeah, so everything comes from moving along. You're going to go down here in aldosterone, you're going to go across here and down to cortisol, and you're going to go across here down to the androgens, the sex hormones. Now, let's put in the numbers. 21 comes first, then 11, right? So as we drew it here, 21 and 11, 21 and 11, so 2, 1, 1, 1, 2, 1, 1, 1, right? Just 1, 11. And of course, what was the 7? Oh yeah, this is 17. I'll put it here, I'll put it here. 17, 17. Now you got the pathway. You know, we didn't do all the details, but you got the pathway. You got the pathway. You know where the blocks are going to be. So let's do the first one. This is the most common one, so let's do it. If I'm missing 21, block, block. Those are the blocks. So tell me, what pathway is still open? The 17. Gonna go this way. Oh, you're gonna get virilized. No doubt about that, you're gonna get virilized because that pathway is still open. Now question, I can't make cortisol. I can't make cortisol. So what doesn't get negative feedback? Well, the pituitary. So ACTH is gonna be really high. ACTH is gonna be really high. And what's gonna happen to my adrenals? Well, it's gonna stimulate them, and they're gonna become huge. You're gonna get adrenal hyperplasia here. Adrenal hyperplasia. Because they're stimulated, but they can't make cortisol. They can't. There's an enzyme block here. They can't. So that's what they call this congenital adrenal hyperplasia. Because if you can't make cortisol, the pituitary's like, work, come on, work, ACTH, work. And the adrenals become huge, but they still can't make their hormones. They can't. They can only make the androgens. So you're going to get really, really virilized. Make sense? Now, what happens to the blood pressure if I block this pathway? Can't make aldosterone, I can't make the weak mineralocorticoids and the strong ones. You're going to get low blood pressure. Makes sense. So blood pressure's low, cortisol's low, and your androgens are going to be high. I love it. It's so cool. Now let's do the other one. So let me erase this and get rid of these blockages that I drew. So get rid of this blockage, get rid of this blockage, get rid of this blockage, get rid of this blockage. Okay, now let's try it. Let's do 17. We'll do an order. If you're missing 17, now we got a block going this way and going this way. Okay, got the blocks here. So again, can I make cortisol? No, I can't go through this pathway. I can't go down this way. So now cortisol is going to drop, ACTH is going to go up, and I'm going to get adrenal hyperplasia once again. Question, am I going to get virilized? No, you got a block going this way, so don't get virilized. No, women do not become mammy here. Now question, what happens to my blood pressure if pretty much everything has to go straight down? Oh, you're going to get hypertension. You're going to make a lot of weak and strong mineralocorticoids in your hypertension. So hypertension, but you don't get virilized because that pathway is blocked. I love it. Let's try it again. So erase these blockages that I drew. I know it's too easy. My brain rejects it. You must make it more difficult for bone. No, it's easy once you do it like this. Okay, now let's do 11. 11 is the last one. Now, we gotta put a block here, and a block here. 11 is now knocked out. Okay, now question, can I make cortisol? Let's see, can I make it? No, I can't make cortisol, so again, ACTH goes up, and you get congenital adrenal hyperplasia. Now, question, can I make androgens? Yeah, that pathway is still open. I can make androgens, so I'm going to get virilized once again. I'm going to get virilization. Now question, can I make mineralocorticoids? Well, I can't make aldosterone, but I can make a weak one. I can get this far down the pathway. So I get this far down the pathway, I'm gonna make a weak mineralocorticoid. So I will get hypertension. Because I'm gonna get this far down, and this area right here, I forget the name of it, but there's a weak mineralocorticoid there. That will give you hypertension. That's cool. So I'm gonna get virilized, and I'm gonna have hypertension, but again, no cortisol, so you get adrenal hypertension. So cool. So again, how did I do it? I just started with saying you're pregnant. You're going to be pregnant with all these different hormones. GFR is coming from all these hormones. And then I said, okay, well, we got a 1, and a 7. That's what these end with. So this was a 1, this was a 1, this was a 7, 1, 1, 7. And then I just say, okay, well, this is going to have 21 and 11, 21 and 11, and this is going to be 17 and 17. So practice it a few times. It becomes really easy to do, and you'll never miss these questions. Again, if you go back and take a look at the details of the chart, your brain explodes. So I like to keep it nice and simple here. All right, now let's go back and finish this chapter. Not too much to go. A couple of clues. So here we were right here. Okay, so we were doing hyperfunction of the sex layer, which is the reticularis, and that gives us the adrenogenital syndrome. Again, they could ask about a carcinoma causing it, but most likely it's going to be a genetic enzyme defect. Autosomal recessive, these are recessive diseases where you're missing 21 hydroxylase or 11 beta hydroxylase or 17, but only the 21 and 11 give you this virilization syndrome. Very good. All right, now that we talked about hyper, we got to talk about hypo. And we're just going to talk about the cortex now, just the cortex. So hyperfunction, adrenal insufficiency. Now there's two ways you can get it. You can get it acutely, or you can get it chronically. If you get it acutely, it usually kills you. If you get it chronically, I can replace the hormones, and you can live. So it really depends on how fast you get it. Now, if you get acute adrenal cortical insufficiency, that's called an adrenal crisis. This will often lead to death. It'll lead to death. Now, what causes it? Well, one possibility is if you had chronic adrenal insufficiency, and then you added some acute stress to it. Acute stress, where you need the gland to make more hormones for you, but it can't. So again, if I have insufficiency chronically, then I have acute stress, and it's supposed to, it can't, that will give me insufficiency. A second way is, what if you are on long-term steroids, your gland really atrophied, and then I stop the hormone segment? That will be an acute adrenal crisis. An acute adrenal crisis. But the one we're most likely to ask about in terms of causes is massive adrenal hemorrhage, which leads to hemorrhagic infarction. Notice these glands are, look at the cortex, it's supposed to be yellow, it's hemorrhagic. I think you can see it's still slightly yellow, the cortex, but it's now hemorrhagic, it's infarcted. So this is very bad. So again, there's three causes. Chronic insufficiency, we get throw the stress on top. Rapid withdrawal of long-term steroid therapy, and then a massive adrenal hemorrhage. Now this can occur, hemorrhage can occur if somebody has anticoagulant therapy. If you anticoagulate you too much, you can bleed. It can happen in newborns after prolonged difficult delivery. It can happen post-surgically in patients who go DIC because you can clot the venous, the outflow. But most likely, for example, it's going to be Waterhouse-Friderichsen syndrome. I made it red because this is a classic pattern of medicine. I remember in my med school, one of my first pathology classes, they gave us a case of Waterhouse-Friderichsen. They had all the organs there, and I had to look at all the organs. I was freaking out. It's like my first day of pathology, they're throwing organs at me. I was like, very scary. It was trial through fire back then. Nowadays, you just look at pictures. All right, now this is bilateral hemorrhagic adrenal infarction, and it's secondary to bacteremia because you had an untreated Neisseria meningitis. So remember, who gets Neisseria? It's usually children and young adults. That's who gets it, children and young adults. That's what we're supposed to vaccinate college kids when they live together in the dorms, and vaccinate military guys when they're going to live together in the barracks. Because in close quarters, that's how it's going to get spread. Now, if you get meningitis, you get vaccinated, you get meningitis, you're going to get septic. When you get septic, you're going to shock, septic shock. That can trigger DIC. If you get DIC with the shock, so hypoperfusion plus clotting, now you can have bilateral infarction because less perfusion pressure and the clots in the venous outflow. So blood can't get out. It's going to basically back up and you're going to hemorrhagic infarction. So this is Waterhouse-Friderichsen again. I want to focus on what's most likely to be asked. That's what they're most likely to ask. This one, and maybe they'll ask about somebody on chronic steroids and they said the patient just stops taking their meds. You should expect acute adrenal insufficiency. These patients come in with no sex, no salt, and no sugar. That's how they're going to present. All right, now unfortunately, Waterhouse-Friderichsen is often lethal because DIC means death is coming, plus your septic, plus your adrenal fail. So the only way I can actually save their lives is if, number one, I can replace the hormones. Number two, I need to give antibiotics for the sepsis, gotta kill the viscera. And number three, I'm gonna have to treat the DIC. Treating the DIC is treating the underlying cause, but you gotta keep the platelet count up so they don't bleed to death. Keep the platelet count up, keep the factors up by giving fresh frozen plasma and platelets. All right, so that's what you have to do for these patients to survive. You feed the DIC while you're giving antibiotics to kill the organism and replace it with adrenal hormones. Again, very hard to do. This is a very high mortality. Now, what if you destroy the adrenal slowly? So again, primary means the gland, you're chronically destroying the cortex slowly. Well, you can survive that easily. I can replace the hormones. This is called Addison's disease. On a 5-star scale, 10 stars again. So Addison's and Cushing's, very testable. Now this is by definition destruction of the adrenal cortex. So now you're missing your sugar, your salt, and your sex. The whole three will be missing. Now the most common cause, and this has been a board question, most common cause of Addison's is autoimmune. Autoimmune adrenalitis accounts for 60 to 70% of all cases. And it may be associated with the autoimmune polyendocrine syndromes, where you attack multiple endocrine organs. Now, other causes that are less common nowadays, but TB actually used to be the most common cause. Used to be back in the 1800s when we had TB and we didn't have any good drugs, but now we don't see much TB and we have good drugs for it. But I bet if you go to India, it's probably the most common cause in India, Addison's disease. AIDS can do it because you get a lot of infections like CMV. CMV can destroy the adrenal cortex. And metastatic cancer, particularly lung cancer, and that was a question. So basically the students said, John, it was Addison's. They showed me a picture of adrenals and I couldn't see them. They were like destroyed. And then they said, what tumor is that? Oh, I couldn't see the adrenals because they were destroyed by tumor. Well, any tumor can go to the adrenals, but what tumor loves it? It's kind of like tropism for it. Lung cancer. 50% of lung cancers, 50% when they spread will go to adrenal glands. 50% of the time. More than half or more of lung cancer has kind of like tropism. The same way signet ring cell of the stomach goes to a woman's ovary. Remember, signet ring of the stomach goes to the ovary. That's called Quickenberg tumor. Well, lung cancer loves the adrenals. It's got tropism for it. Okay, now, how do I know in the first place the patient has Addison's? What are they going to give me clinically? Well, let's see. I'm missing sugar, salt, and sex. So I'm going to be weak because of the sugar. I'm going to get hypotension because of low sodium and high potassium because of aldosterone deficiency. I'm going to get hypoglycemia and poor response to stress because of cortisol. I'm going to get loss of libido and impotence because of the sex hormone. Sex hormones are missing. But why do they get hyperpigmented? So look at this. Compared to this person, that's it's darker, especially on the crease line. See where the crease lines are very dark and these creases? That's compared to this guy, who's normal. This hand is like, whoa, it's very high. Look at the creases, the crease lines. Yeah, they get hyperpigmented because of ACTH. Yeah, very good, the precursor, very good. So POMC gets broken down. One component is ACTH. Now, if you actually break down ACTH, one part of ACTH is melanocyte-stimulating hormone. So that's part of ACTH molecule. It's melanocytes. It's part of the molecule. So unfortunately, when you have cortisol deficiency, ACTH is going to go through the roof, and that is going to give you melanocyte-stimulating hormone effects. You're going to get bronzing. In fact, what president was kind of bronze like a movie star? He dated other movie stars secretly, or not so secretly. Do you remember JFK? John F. Kennedy. We think he had Addison's. Actually, we know he had Addison. He had Addison's. That's one of the reasons he was like a movie star. He was so dark. Yeah. And listen, he was a president during the Bay of Pigs invasion, where we almost got World War III because poor decision. We decided to invade Cuba over the nuclear missiles there, and they almost launched the missiles at us. Yeah, thank goodness he came to his senses. Look, poor response to stressful situations. Maybe this played a role. Maybe this played a role in those decisions to invade Cuba and almost start World War III. Interesting. Now, clearly, he is being treated very well because treatment is steroid replacement. So do you think he was getting replacement androgens? Happy birthday, Mr. President. I think, yeah, he was hanging out with Marilyn. He was chasing Marilyn all over the place. He was like the original Bill Clinton, right? I think he was getting plenty of replacement, and he might have taken extra doses of the androgens. So you gotta replace the cortisol, you gotta replace the mineralocorticoids, and you gotta replace the sex hormones too. So I think he was getting substantial replacement. So maybe it wasn't his poor decision, maybe it was the military's decision. All right, so that's fun. Whenever a celebrity has a disease, it's always important to learn about it. All right, now let's talk about some tumors. We did hypo, we did hyper for the adrenal. Now we're going to talk about tumors. Now we actually talked a lot about the adrenal cortical tumors already. We talked about them a little bit. So let's just put here, functionality is based on the clinical evaluation, right? So we're not going to do a CT or MRI first. We're going to do clinical exam to see if I see effects of the hormone. And of course, we're going to check the blood hormones or their breakdown metabolites. So again, it's really clinical and biochemical demonstration of endocrine diseases, which are confirmed by doing imaging. Imaging is always the last thing to do. Now, if it's an adrenal cortical adenoma, a lot of them are silent, so you'll find them incidentally. But if they are functional, the adjacent cortex will be atrophic because the tumor is actually making the hormones. And of course, if it's making aldosterone, you get COGS. If it's making cortisol, you get Cushing's. If it's making the sex hormones, you get the adrenal genital syndrome. Okay, so those are the three classic adenomas. But remember, adrenal genital syndrome is usually due to carcinomas. It can be due to adenomas, but usually it's due to carcinomas. So actually, I put it down here. Because adrenal cortical carcinomas are more likely to give you virilization and adrenal genital syndrome. So again, could be due to adenoma, but more likely it's due to carcinoma. Again, I cannot tell if a tumor is malignant in the endocrine system under a microscope. I don't have those classic features you see with other tumors. So I need to look for metastasis and invasion. That will tell me the tumor is more likely to be malignant. All right, now what about this tumor? It's not yellow. Here's the cortex. Cortex looks good. This is a tumor of the adrenal medulla. It's like a red-brown dusky tumor. This is called a pheochromocytoma. It's also known as a tumor of chromatin cells. Chrome, color. That's why it's dark and dusky. Now let's talk more about that. Pheochromocytomas. This is an example of things that are very rare that get tested like insanely large amounts on exams. They really like to ask pheo because it's very characteristic, it's very sexy, but they're just not very common. As a pathologist, I see them a bit, but man, as a clinician, if you see one in your lifetime, that's gonna be a lot because these are pretty rare tumors. And I know, on exams, they say patient's hypertension, you think pheo. In real life, patient's hypertension, oh, well, they're like, join the club. It's sexual hypertension, right? All right, now for pheo, this is a tumor of the chromatin cells of the adrenal medulla, which don't forget come from middle crest. These are neurocrest cells. So can anybody tell me what stain will be positive? Neurocrest? Oh yeah, S100. These are for neurocrest. Now they're going to produce catecholamines. Epinephrine, norepinephrine. Norepinephrine, and epinephrine. That's going to produce large quantities. And again, this is a rare, surgically correctable type of hypertension. Because if I remove this tumor, it's usually benign. If you remove it, now you'll remove all these catecholamines, and your hypertension should go back to normal. Now, this is what's called a rule of tens for Theo. A rule of tens. We have a rule of twos for Meckel's, a rule of twos for Meckel's, we have a rule of tens for pheochromocytoma. 10% are extra-adrenal, which means 90% are adrenal. They're an adrenal adult. But 10% are extra-adrenal, and they give it fancy names. They're usually tumors of the sympathetic ganglia, so they call them paragangliomas. Now, I'm starring this because students say, John, it was a Pheo. All the clues for Pheo, all the findings for Pheo, it was a Pheo. But Pheo wasn't a choice. It wasn't there. I freaked out. I was like, dude, was paraganglioma there? He goes, yeah, I didn't know what that is. That's the name for a Pheo when it's outside the adrenal gland. It's a Pheo. But outside the adrenal gland, they changed the name. He's like, son of a gun, that was there. I didn't know what that was. I crossed it out. No, that was the right answer, dude. And unfortunately, when it's out of the adrenal, it's more likely to be malignant. Look at this, 20 to 40% are malignant when you're a paraganglioma. So that's kind of important to know. They changed the name because higher rate of malignancy. All right, so 10% are out of the adrenal, most are in the adrenal. 10% are bilateral, which means 90% are unilateral, so they're usually one side. 10% are malignant, which means they can spread, but 90% are benign. So Pheos 90% of the time are benign. Now, 10% are not associated with hypertension, which means 90% have hypertension, but not all the time. They have what's called episodes or paroxysms. They're episodes of hypertension, episodes of sweating. It's not all the time. So look for episodes of sweating, episodes of hypertension, episodes of palpitation. It's episodic. In fact, if you push on where the adrenal is, if you push on that area, you can actually stimulate it to release catecholamines and you get an episode. You actually push on it. In fact, when they do surgery, be very careful, because when they go in and surgically manipulate it, they'll get hypertension intraoperatively. So they need to prevent that by putting them on some of the alpha blockers during surgery to prevent a sudden surge or release, get hypertensive crisis. Operative, not good. All right, so 10% are no hypertension, most cases have hypertension. And then we have another 10% rule, 10% harbor a germline mutation. We revisited this and we realized it's more than that. So we're gonna modify it now and make it 25%. 25% of Pheos have a germline mutation, which means they're probably part of a syndrome. They're probably part of a syndrome and they have multiple bilateral other tumors as well. For instance, RET mutations are very common, especially if they have the multiple endocrine neoplasia, 2A or 2B. NF1, so this could be associated with neurofibromatosis. VHL, this could be associated with von Hippel-Lindau syndrome. So these are the genes that you're going to see. RET knockout, NF1 knockout, VHL. These are classic germline mutations that it can be associated with. Now, when you do have a germline case, again, it's 25%. They tend to present younger than a sporadic Pheo. They often are bilateral. You can check both adrenal glands. And the incidence of malignancy is much higher when it's genetic. So approximately, the approximate size will come out, but approximately 30% chance of malignancy when it's genetic. So Pheos are 90% benign, unless they're outside the adrenal, they call it paraganglioma, more likely malignant, or if the Pheo is in a germline situation. So if it's an MEN syndrome, if it's neurofibromatosis, von Hippel-Lindau, there's a higher rate of malignancy. But again, 30%, that means 70% are still benign. So usually benign tumor. All right, now some fun things about it. Chromaffin. These are tumors of chromaffin cells. Why do they call it that? Well, when I first became a pathologist, as the first one of these I got, they made me cut a slice of it, take that slice of tumor and put it into the solution of potassium dichromate. When you put it in there for a little while, it turns dark, dark brown. It was so cool. So right, it's kind of brownish red. You put it in there, it turns like mahogany brown. It was so cool. That is a chromophene reaction. Because of these chromophene chemicals, this potassium dichromate makes it turn brown. So that's just a fancy way to say, okay, it's a chromophene cell tumor. Now, under the microscope, and again, they're never going to ask you about this reaction. I'm just putting here because it's cool. So that's why they call it chromophene cells, because they turn brown. Chrome, they turn color when you add another chemical. That's just cool. Now, what they'll ask you is under the microscope, you're going to see polygonal or spindle-shaped chromophene cells in nests. Do you see the nests? They got this delicate reticulum around them. Making these nests. They're cool, like little balls. Exactly, they're like little balls. Exactly. So we give this a fancy term. When the tumor grows like this, we call this a Zellballen pattern. Zellballen, it's like little balls. It's so cool, Zellballen. So a tumor with Zellballen pattern growth, that's a pheo. So remember that term, Zellballen, nests of cells. Very classic for this tumor. Now, on electron microscopy, I'm going to see these membrane brown granules. Well, that makes sense, because these tumors are secreting catecholamines. So they're going to have neurosecretory granules that have catecholamines in them. Makes sense. Now, nuclear pleomorphism is common. So again, if you have funny different nuclei, in most tumors that means something. You got big nuclei, small ones, you're like, oh my God, that's the lady in Pittsburgh. That's usually a bad finding. But here, you can have funny looking nuclei. It doesn't mean it's going to be malignant. It doesn't mean it. So here we got to look for invasion of the capsule, invasion of blood vessels. Okay, but actually that can actually be seen with benign lesions too. What? Yeah. So the only way for pheos to be called malignant is if it is metastasized. Weird, huh? So pheos can actually be invasive and actually invade blood vessels. But they don't, until they spread, until you see them somewhere else, then you can call them malignant. Otherwise, you can't call them malignant. Wow, so they look malignant, they can smell malignant, but until you see the whites of their eyes, until you see them actually in another spot, you can't call them malignant. Wow, crazy. You just see invasion, I'm like, oh, it's malignant, gotta be malignant. No, I'll put in the report, invasion, so you better look for metastasis, because when I see this, you probably have metastasis, but unless I see metastasis, we consider it benign. Yes, benign. All right, now clinical. You look for episodes of hypertension, episodes of tachycardia, episodes of palpitation, episodes of sweating, and of course, tremor, muscular tremors. Now, for the laboratory, again, we don't want to do imaging first. I get this history. I want to do biochemical analysis first. Okay, what can we look for in the urine? We can look for free catecholamines, epinephrine, norepinephrine. We can look for the breakdown products called vinylmandelic acid, VMA. That's a classic one. You can look for HVA, homovinyllic acid. You can look for free metanephrines, and you can look for this in the plasma or the urine. So urine, urine, urine. This could be plasma or urine. So let me stop right there. When I was in med school, they told me, pheo, get VMA. Pheo, get VMA. Pheo, get VMA. Everybody seems to know that. So now they'll ask, what else can you look for? VMA is not a choice. Look for HVA, homovinyllic acid. Homovinyllic acid. But both of these are not the best anymore. The best biochemical marker in the blood for pheochromocytoma is free metanephrines. That is the best. You can look for it in the urine or the plasma. This is your most sensitive marker. Best marker to do. So again, I'm going to do all three in real life. I'm going to order VMA, HVA, and metanephrines. I'll order them all. But on the exam, I can only pick one. If they're all there, you go for metanephrines. Metanephrines is your best. But if that's not there, look for VMA or HVA. One of these three will be on your exam. Okay? Now, in terms of staining the tumor, I can stain with chromogranin A. That's very important. Chromogranin is one of the neuroendocrine markers. Chromogranin or non-specific enolase, because these come from neural crest. So neurons versus adrenales, chromogranin A, these are markers of neuroendocrine. Then finally, you can pick up a CT or MRI and look for an adrenal mass. Again, we don't routinely do CT or MRIs of adrenals because you will find stuff. You'll find nodules, and then you're like, oh crap, what is it significant? Is it a tumor? What is that nodule there? So we don't still routinely do CTs and look at adrenals because you'll find stuff that we're not looking for. All right, now treatment. How are you going to treat this? Well, surgical, but I can't take you to surgery with episodes of hypertension. In fact, when I surgically manipulate it, you're going to get high blood pressure. So we got to start antihypertensives before the surgery and during the surgery to prevent a crisis. So here's the rule: alpha drugs first. Alpha drugs first. Always do alpha blockers first. So look at the name. Phenoxy. Do you see the pheo? Phenoxybenzamine, non-selective alpha blocker. And then you do this before, see the BE, before surgery. So as soon as I make this diagnosis, I'm gonna start phenoxybenzamine. Now, intraoperatively, I want a short-acting one. So the short-acting one is phentolamine. Again, you see pheo, this is the one you do during surgery. And again, we're using it less and less, but this was classically used during surgical intervention. So before we put you on phenoxybenzamine, then intraoperatively we'll switch you to phentolamine. So alpha drugs first. Now, if this is not sufficient to control blood pressure, then you can add calcium channel blockers or beta blockers or may have all three. But again, if you start beta blockers first before the alpha, if you start beta blockers first, you will get unopposed alpha. Unopposed alpha will actually give you paradoxical hypertension. But John, I put you on beta blocker. I know. You put me on beta blocker, lower my blood pressure, you just raised my blood pressure because you gave me unopposed alpha. So again, in terms of blood pressure, we always want to do alpha blockers first, then you can add beta and calcium channel blockers. Alpha first, don't do beta blockers first, you get unopposed alpha. Now I can do a laparoscopic adrenalectomy and remove your adrenal gland, and usually your tumor is better now. After I take it out, your tumor should be better because I got rid of the source of all this epinephrine neuropathy. All right, we got one last thing, actually two more things, and then we're done with this chapter. So we'll finish up here real quick here. Okay, multiple endocrine neoplasia. There's multiple endocrine tumors and hyperplasias. No. It's a group of hereditary diseases we see proliferation, so either hyperplasia, adenomas, or potentially carcinomas of multiple endocrine organs. That lives up to its name. All right, now compared to sporadic tumors, when you have MEN syndrome, they're going to create downward. They're going to arise from multiple organs. They're going to have, they're often preceded by hyperplasia first. So often we'll see areas of hyperplasia, and then you'll develop an adenoma. And they're more likely to be multifocal tumors and more aggressive than a sporadic one. And this applies for any basic genetic cancer syndrome. It's going to be younger, it's going to be more bilateral, it's going to be more aggressive. Now, men, MEN, men. Are men dominant or recessive? Men. All right, we're having some controversy here. Okay, let me rephrase. Do men think that they're dominant or recessive? Okay, now we have agreement. Men think. I know, ladies rule the world. I'm with you, ladies. But men think they're in charge. So these are all dominant diseases because we think we're dominant, even though we probably aren't. But we think we are. All right, now there's three types. MEN1, I remember like this. Another name is wormers. I know it's Werners, but close enough. One is like a worm. So one is also known as wormers. See, because they're always going to use the names you don't know. So if we call it MEN1, they'll call it wormer. But if I call it wormer, they call it MEN1. So one is like a worm. So wormers, close enough. All right, now, this is a mutation in the MEN1 gene. That makes sense. It's going to make a protein called menin. No way. Menin. So that's like MEN1. This is so easy, that's the protein. Cool. So MEN1 gene makes menin protein. That's a little too easy. So more likely they're going to ask you, what are you going to see here? Well, I remember the four P's. The four P's. MEN1 is the four P's. So let's draw a really long guy, make it really long, really long. We're going to start at the head and we're going to work our way down. In the head, what is, I'm going to put a P here in the head, four P's. P in the head, P in the neck, I'll put a P in the neck. I'll put a P in your belly and then another P. Okay, so four P's. One in the head, one in the neck, two in the belly. Okay, the first three are benign adenomas. So what's the name of the endocrine organ at the base of the brain? Base of the brain starts with a P? Oh yeah, that's a pituitary. So getting pituitary adenomas. Yeah, pituitary, oops, this was a T. Pituitary adenomas. Yeah, now what do they make? Well, they can make anything. We saw them. The most common was a prolactinoma, so I'll put that here. Prolactinoma. But they can also make growth hormone, they can make ACTH, and they can make whatever the heck they want. So that's cool, because we talked about those tumors already. So again, pituitary adenomas, I'll just raise it a little bit. Pituitary adenomas, making prolactin or growth hormone. It's supposed to be pituitary. Okay, now the second organ is down in your neck. What's next to the thyroid that has a P? A parathyroid. So you're going to see parathyroid adenomas. Parathyroid adenomas. So again, adenomas. Now, what do parathyroid adenomas make? Well, they're going to make PTH. So you're going to have high PTH, parathyroid PTH. So that's going to lead to hypercalcemia and kidney stones. Hypercalcemia and kidney stones. So very important, hypercalcemia and kidney stones, because parathyroid adenomas are going to make PTH. All right, so we got pituitary adenomas, we got parathyroid adenomas, now we go to the belly. What's the endocrine organ in the retroperitoneum starts with a P? A pancreatic adenoma. Pancreatic adenoma. Pancreatic adenoma, better known as islet cell tumors. Islet cell tumors. And remember, the most common was an insulinoma. But you also had a G cell tumor, a gastrinoma too. So those are the two most common. So we have it listed. So again, we got pituitary adenomas making prolactin or growth hormone. We've got parathyroid adenomas making PTH. Now we got pancreatic adenomas, islet cell tumors making insulin or gastrin. Now, if it's making gastrin, do you remember Zollinger-Ellison syndrome? Zollinger-Ellison syndrome will occur if it's a gastrinoma. Zollinger-Ellison is when I had way too much gastrin. So now I got proliferation of parietal cells. I'm a big folds with parietal cells, and I'm a big acid. So that last P stands for peptic ulcer disease. Peptic ulcer disease, I could barely fit it in. Anyway, peptic ulcer disease, that's what that last P is for, peptic ulcer disease. Anyway, learned it again. I tried. Peptic ulcer disease. All right, so I just remember the four P's of MEN1. Four P's, three adenomas, pituitary, parathyroid, pancreatic, and then because of the pancreatic islet cell tumor, it is making gastrin, you can get peptic ulcer disease. Remember, really hard to control. Gotta need omeprazole here. You're gonna need a proton pump inhibitor like omeprazole to control that peptic ulcer. All right, that's pretty cool. Now, MEN2A and 2B. Well, 2A, that's not simple. 2A, can't just call it 2. 2A, that's not simple. That's simple. It's not simple, but it's simple. 2A. I know, it's kind of weird. And then we got 2B. 2B, it's also dominant. And notice, they both have mutations in RET. They're different mutations, but they're both in the same gene. So these tumors look very similar, because what do they have in common? Well, they're both going to have medullary carcinomas of thyroid. Medullary carcinoma of thyroid, which can kill you. It's a malignant tumor. very aggressive. But they're also going to have pheochromocytomas. When we talked about pheos, they're usually benign. Now, in this syndrome, they have a higher rate of being malignant now. Okay, so they're both going to have medullary carcinoma thyroid, and pheochromocytoma. Perfect. So they're identical. They're identical because they got the same gene. So they're both going to get medullary carcinoma thyroid, which is malignant, and they're both going to get pheo, which is usually benign, but does have a higher rate of patients here. Okay, that's what they have in common. So if you want me to separate them, you got to give me something different. They both have RET mutations. They both have medullary. They both have pheo. You got to make it different. So for MEN2, we're going to add something. What are we going to add? We're going to add parathyroid, either hyperplasia or adenomas. Either one. So that's what's going to make 2A different. So they're going to have high PATH, high PTH, and they're going to get calcifications. So hypercalcemia. Okay, so let's repeat. What makes this different? How do I know to pick it? Well, when I see medullary carcinoma thyroid and pheo in the same patient, I'm thinking MEN2. But is it 2A or 2B? Look for the hypercalcemia kidney stones. If you see hypercalcemia kidney stones, it is 2A. Now for 2B, I gotta add something different to that one too. I gotta add something different. So what we're gonna add to this one is we're gonna add, number one, marfanoid features. Marfanoid features. Yeah, tall, long extremity, spider-like fingers. All those things we saw in marfans can occur in MEN2B. In fact, this is what we think Lincoln had. Do you remember Lincoln was like marfanoid? He's really tall. Well, we think he had MEN2B. He was meant to be the president. He was meant to be it. We think if he didn't get assassinated, he would be at risk for pheo and potentially medullary carcinoma. Because we think he had MEN2B, but the family won't allow the DNA to test it. But we think so. We think it. Now, or if you don't want to give me the marfanoid features, then you give me benign neural tumors. Benign neural tumors. Neural tumors like a neuroma. Like a neuroma. That's a benign neural tumor. Or how about a neurofibroma? Yeah, you can get neurofibromas and not have neurofibromatosis. Yeah. So let's repeat. Benign neural tumors like a neuroma, like a neurofibroma, but the one they really like is a ganglioneuroma. So I'm going to put it here, ganglioneuroma. Again, benign neural tumor, but ganglioneuromas are usually found in the GI tract. GI tract, that's usually what you see, right? Neuromas are in your skin, neurofibromas in the skin, ganglioneuromas usually in the GI tract. So here's how they're going to test it. They're going to say a guy comes in with episodes of hypertension, sweating, VMA is elevated in his urine, and everyone's going to be thinking, it's a pheo, it's a pheo, it's a pheo. Well, we want to make sure it hasn't metastasized, right? So they may do colonoscopy, make sure it hasn't spread to the GI tract, and they find a polypoid mass. Like, oh, that's got to be metastatic pheo. They remove it, and the lab says, no, it's a ganglioneuroma. A ganglioneuroma. This is like, what is that? I was like, dude, if you got a pheo and then you have a ganglioneuroma, you got MEN2B. And then the vet says, what should I look for in the future? Well, you better watch him now, because now he's got two tumors, so he's already got MEN2B. So you better watch him for medullary carcinoma thyroid. You better watch him for that. In fact, forget watching him for it. Prevent it. Prevent it. Once we know you have 2A or 2B, we can do genetic testing, look at the gene. Once we've confirmed it, you want to remove the thyroid, because this is a potentially preventable cancer. So patients who demonstrate germline mutations in RET should have prophylactic thyroidectomy. Because if I remove your thyroid, I can give you Synthroid. For the rest of your life, you take Synthroid. Get thyroid replacement, you're all good. But if I leave it in there, you would get a malignant tumor, which would kill you. There's no excuse for that. So you take the thyroidectomy and give the Synthroid. Do not allow them to live with that thyroid gland. That's like a ticking time bomb. So again, when a patient comes with a neurofibroma or ganglionomas, we're going to suspect MEN2B. We'll do germline testing for RET mutation. If they have it, we do prophylactic thyroidectomy. Easy for the board to test that. Very easy for the board to test. So these MEN syndromes are very high yield. They like to test them. MEN1, the 4 Ps, MEN2A and 2B look very similar because they have RET mutations. They're different mutations, but it's still in the RET gene. So very easy to remember that they both have two tumors. What makes them different is the cave. Arsenoids and benign neural tumors for 2B, parathyroid adenomas leading to hypercalcemia and kidney stones for 2A. Cool. All right, now the last of the endocrine organ is your third eye. I have a third eye? Yes, you're all seeing, all knowing. You have a third eye. You do. It is called the pineal gland. And I was like, why do they call it that name? Because it looks like a pine cone. It literally looks like a pine cone. It's back here at the back of your brain, so here's your front, here's your back, here's the cerebellum. It's little nubbin back here. It kind of looks like a pine cone. So they call it a pineal gland. It's located at the base of the brain in the midline. Now it's composed of pinealocytes. What's their function? Well, it's photosensitive, so it is a third eye. Photosensitive, it's going to sense light and release melatonin. And also a neuroendocrine, because it's going to release melatonin, so it's endocrine, right? Neuroendocrine. So very important, melatonin is going to create this circadian rhythm. So as we see light, that light, that signal, will go back to the pineal gland and tell it to make melatonin so we can create a circadian rhythm. So we awake during the day, we sleep at night, we have this rhythm, we have this clock. Sometimes I wake up, like I have to get up at the same time every day. So like on a weekend, I have the day off, but I still get up at the same time because of that circadian rhythm. You just get this clock and your body knows it's time to wake up. So very important to have it. In fact, if you're going to fly and go to different time zones, some of the teachers, like when they're going to travel to Europe and teach in Europe, they take melatonin to try to get them, because the time changing the time zones, it kills you. Your body doesn't know what's going on. So they take melatonin to kind of regulate the circadian rhythm, get them back on board. Very interesting. All right, now in terms of board questions, they're most likely to ask about tumors back here. And there's really only two kinds of tumors. Number one, 50 to 70% of all tumors of the pineal gland are going to be germ cell. They're germ cell. They're going to call them germinomas. So either a seminoma or a dysgerminoma. Seminomas and germinomas. Isn't that weird? You get these in your testes and ovary, but you can get them in your third eye, your pineal gland. Now, another tumor you can get is called a pineoblastoma. Pineoblastoma, notice the word blastoma, small round blue cells, very immature, neuroendocrine. Now, this is associated with retinoblastoma. So this is called a trilateral retinoblastoma. It's like the trifecta. If you have familial retinoblastoma, you can get it in one eye, you get it in the second eye, and then you can get a pineoblastoma. That's like your third one. So that's like the trifecta. So you can have unilateral, bilateral, and now trilateral retinoblastomas. So you didn't know you had a third eye, did you? So it's like a retinoblastoma of your pineal gland, they call it pineoblastoma. So cool, isn't it? So cool. I love this stuff. The body is an amazing thing. Now again, out of all these endocrine organs we talked about, this pineal gland is by far the lowest yield. I think it's fascinating. Third eye. Wow. Vertical gaze palsy, that's a good question. You know, I'm not sure if it would create a vertical gaze palsy. I don't know. What's back here? I don't know. I haven't seen that many in my career. I don't do any neurosurgery except when I was a resident. So even when I was a resident, I never saw one. So I don't know. I haven't seen enough of them to tell what the presenting finding would be. I'll have to go Google it and look it up. Yes, if you have a tumor here, you can have trouble with sleeping. Yes, your rhythm gets messed up. You have a tumor of your pineal gland. Absolutely. Okay. Protect. Oh, interesting. Yeah, whatever's here neurologically, that will get mass effect. You got whatever's nearby, it will push on and give you those kind of symptoms. So whatever's over there, I'm a little bit rusty. So, Sam, that's our 2 questions to find out about what's there. Compressing the prefrontal area. Very cool. So would that give you a vertical gaze palsy if you compress a lot? I guess. Interesting. All right, I got to learn more about it myself. Because this is as far as I know. I've never seen the actual case of it myself. But you seen a Euro question on it now. All right, perfect time to take our break. We'll come back and then we'll start a totally different subject. We'll start bone pathology. All right, see you in a little bit.
That was the joke. He laughed. I got you. This actually is from my ski trip. These things don't go bad, do they?
Yeah.
Yeah.
After about 2 months.
No, we get it dries. It dries.
Yeah, very good. Farm properly.
You're gonna eat it.
I've got too good, you fucker.
It's awkward the other day, the doctor just sat me down. Like, what do you? It was to be a lot better now than less than I thought.
Sounds like your guy took this pretty seriously.
What's interesting, he's never had a second year before. He's only had third, fourth years. So he's kind of like, why don't you know this guy? But, yeah. I'm kind of proud though because there's one, when I was deer hunting, a bunch of my dad's and his friends, some of the doctors too. They told me the biggest thing, not the biggest thing, but the really important thing is like, if you don't know the answer for residency, that makes sense. If you don't know the answer, don't bullshit, don't know the bullshit. Just say you don't know. And I did that this time. The guy actually got said, yeah, you know. Like, it was nice, it was good. Basically just said it was good that when I asked you a question, you didn't stutter on it and try to come up with an answer because at least told me you didn't know. I feel like the Venn diagram on the first day is better than that.
Yeah. I always get those wrong. Yeah, I spend a lot of time on
I think the key is, if it's just pituitary and pancreas, I remember pit pain for one, since in the top bubble, if it's just that, it can only do one. If it's just the ganglion, bone, stuff like that, or heart, and all that stuff, it's 2B and everything else is pretty much.
What's the overlap between 1 and 2A?
1, 2A is anything not, thing that's unique to men 1 is pituitary and pancreas. Those two are only 1.
So 2A can have oh yeah.
Pituitary and pancreas are only men 1. I'm only did the hand in here. I'm gonna play this one with my girl Jaquisha.
Yeah, I gotta fill up my water anyways.
Me too. Me too, though. Would it help if I had that question on me?
Someone was actually.
It would be like one of those things where you don't say anything.
You just, what do you say?
Move. Go first, you go.
You have to sit there.
I'd probably go with
Excuse me.
Yeah. I don't know what I did. I probably ended up just not saying a word. Just
You all right?
pissed off.
You okay?
Are you feeling it, Mr. Krabs?
get the thing? It says I'm reading you. How do you do this? Hello?
Hello?
Hello? Can you,
Wow.
can you? What's your, hello?
It's giving me after the call. Oh, wait a minute.
Huh? Hello? Oh. Oh.
It's giving me the, it has the muted.
There we go.
Try it.
There you go. How did, what'd you push?
There was a. It's good. You should right there. Yep. You call me. Yeah, I just clicked that. I was like, see this.
There you go.
Can't hang up. How did you?
Oh.
You don't know. Like Nick will call me.
I accidentally,
Did you do it on your?
yeah, I accidentally did that.
Okay.
Yeah.
Yeah, I took a look online and sure enough, you're right. Definitely, no doubt about it. In that area, the pineal tumors usually present with two things. The aqueduct of Sylvia is right nearby. So pushing any aqueduct of Sylvia is going to cause obstructive hydrocephalus. So increased intracranial pressure with nausea, vomiting, headache, projectile vomiting, all those things we think of high ICP are going to occur. And also visual disturbances. Apparently there's a lot of things there that are important for vision. So movement problems, problems with double vision, very, very common. So that's only two questions. We got to drive our stuff. This is so cool. Love it. So thanks for bringing that up. Always nice to know what's nearby in the brain. So visual and intracranial pressure because of obstructive hydrocephalus, two of the important things. Do people who are blind have trouble with sleep? Absolutely. Absolutely, because they can't sense light. So they still release melatonin, but it's not stimulated by the light. So they have to be very regimented about knowing what time it is and when they should go to sleep and when they don't go to sleep. Because they don't have any cues. There's no cues from light for them. So it'd be difficult. My roommate in college was blind, and he had a watch that would talk to him and would tell him it's time to go to sleep. Because he might need to stay up all night long. The day, night, didn't really matter to him, he just kept going. So yeah, they can definitely have disturbances in sleep. Gotta create their own rhythm. All right, let's start the recorder, and now we'll move on to a different category of disorders. Record. Okay, so bone and joints. Now, yield goes down, but there's still some very important things here. Osteoporosis, most common bone disease known to man. There's going to be Page disease, there's going to be bone tumors. So there's still a lot of things that are very testable, but certainly the yield goes down. It definitely goes down. But let's get points, baby points, and maybe some of you guys may want to become an orthopedic surgeon. If you want to be an orthopedic surgeon, knowing about bone and joints, very important. And of course, joint pathology and osteoporosis. You're going to, even if you are a, family physician, if you're in internal medicine, people are going to come in with osteoporosis questions, and patients are going to come in with arthritis. So degenerative arthritis is incredibly common. So learning it is probably a good idea pretty much no matter what specialty. I guess if you're in peds, not too much rheumatoid arthritis in peds. But there is juvenile form. So even if you're going to go to peds, you shouldn't put this out. All right, so let's start off with bone, and we're going to start with the foundations. Again, I always like to do a little framework at the beginning, and then we can build on it and just do the basics first. So for basics, why do we have bones? What are bones for? Well, number one, mechanical, right? They're strong. So there, this is my helmet. This is my helmet to protect my brain. So we got ribs to protect our other organs. We got a pelvis. They're very protective, right?
Yes.
They give us rigid support as well, and they're very important for levers, for muscle. So muscle has to pull on something. Without a bone, you'd have nothing to lever. We'd be able to move. We'd just be amoebas with our pseudopod. So it's important to have muscle to have structure, so not amoeba. Now it's also, and everybody seems to know that makes sense, but it's also our major storage site. It's where we store our minerals, particularly our calcium, our phosphate, our magnesium. They're all stored within our bones. Now, another thing that students don't really consider is it's your home for your blood production. This is where we make our blood. It's made in our marrow. And if we remember, in our marrow, we have all these purple dots are the precursor cells, and then we have fat. Now, it depends on what age you are. The younger you are, the more precursors versus fat. The older you are, the more fat versus precursors. At your age, it's roughly about 50-50. So 50% fat, 50% blue, purple dots here. These are the precursors. 50-50, that's normal marrow. And notice it's growing in between the bone. This pink stuff is the bone, trabeculae. So in between it, that is where our marrow is going to sit. So it's a nice home for our blood. That's where we make our blood. Now, in terms of types of bone, we have two types. The surface of the bone is very dense and hard. That is called cortical bone. That is the dense, compact bone, very strong. That's where the ligaments are going to attach, the muscles are going to attach. That's the outer bone. So this is thick cortex. Okay. Now, inside the bone, you have these little trabeculae. Bony trabeculae. And then in between is the marrow. So the bone marrow would be in between. These are the trabeculae, and the cortical bone is not shown in the picture. Okay? So this is the cortical bone, and these trabeculae are called cancellous bone, trabecular bone, cancellous. Now, the importance of it is the cortical bone has a nice surface for attaching muscles and ligaments too, right? But there's not much surface area compared to all of the surface area of these. Look, you got surface area on this side, you got area on this side. So this has a very high surface area to volume ratio. Because if I'm going to use this as my storage of calcium and other minerals, I have to be able to get at the stores. I got to get to those stores so I can store it and then take it back out when I need it. So this is where your body is going to take from. It's going to take from and deposit from these cancellous trabecular bones. So later on when we talk about osteoporosis, it's these trabeculae that will get really, really thin first. Then the cortex will be involved too. But initially, it's going to be here where we're going to steal the calcium from. We're going to steal it from these edges here. This is where all the osteoclasts and osteoblasts are going to be lined up around, and they're going to actually start breaking the bone down from here. Okay, a lot of surface area for access to the minerals and other things that are found inside bones. Okay, now histologic types. Under the microscope, there's two types of bones that can be found. We have what's called woven bone, and we have lamellar bone. Okay, so I've got two pictures here. Okay, now woven bone is rapidly produced. So when would I want to make bone fast? Well, if I'm a growing fetus, I want to make myself some bone. And I want to make it pretty fast. Infants and fetal tissues growing quickly, you'll make woven bone. And you also want to see it when you have a fracture. When I have a fracture, I need to repair the bone as fast as I can. So initially when you have a fracture, you're going to make woven bone, and then it will get remodeled. Just like fetal tissue will get remodeled into lamellar bone, which is strong bone. Okay, so it gets remodeled, replaced, and reformed as lamellar. Okay, but woven, we'll see it in fetal tissue and fractures. Now, why isn't it so good? Because if you lay it down quickly, you're just throwing the collagen down as fast as you can. It's not arranged for strength. You didn't line it up. So if we take a look at these pink lines here, these are called cement lines. And these pink lines here, they're going every which way but loose. They're going all different directions. See that? This is what woven bone looks like. So that means the collagen is kind of haphazardly arranged here, and therefore it's more likely to be a weaker bone that can fracture. That's not so strong. All right, it's also more cellular. If you take a look at these spaces here, these are little Kuhner spaces where the osteocytes are. Osteocytes are inside here. Notice compared to the lamellar bone, they got osteocytes here too, but less of them, less of them. So it's more cellular and it's more disorganized. Now here's the key. You should only see woven bone in fetal tissue. If you see it in adults, it's always abnormal. It must be a fracture or maybe a tumor or something, because we always find lamellar bone in adults. So woven bone in adults is always an abnormal finding. Either it's a fracture or some other pathologic condition. Now, adults should have what's called lamellar layers. We want to layer the collagen, get them all aligned for maximum strength. So this is produced more slowly because it's carefully arranged. You get parallel arrangement of collagen, and it gives high strength to the bone. So if you take a look here, I think you can see everything is kind of lined up here. It's all kind of lined up. All these lines are going the same way. It's got layers, layer upon layer upon layer upon layer for maximum strength. It's layered. Over here, you see the layers going this way. They're all lined up. They're all lined up. So that's called lamellar bone. Things are lined up like that. That's strong. That's strong, very strong bone. All right, now let's talk about formation of bone. How do we actually make bone? Well, there's two ways you can make it. You can make it from a cartilage skeleton or scaffolding. So first it's cartilage, then it becomes ossified, becomes bone. So that's called endochondral or enchondral ossification. Or you can have what's called intramembranous ossification, where bone just forms on top of bone, forms on top of bone, forms on top of bone, without a cartilage-like architecture first. So again, cartilage becomes bone, or you just make bone. Those are the two ways you can make bone. Now, which bone is made from cartilage matrix? Well, the long bones. So your femur, your humerus, your tibia, your phalanges, anything that's a long bone is made from a cartilage matrix first. Okay, so it develops from a cartilage mold, which is called a growth plate. That's where you make your bones. And this is called longitudinal bone growth. So the bone will grow longer and longer and longer. As this growth plate keeps making bone, it's going to get longer and longer and longer and longer. You're growing from the growth plate. Now here's what a growth plate looks like. Okay, we got 5 zones here. This first zone is the reserve zone. These are where the cartilage cells, these chondrocytes, they're just sitting around just waiting. Then we have the zone of proliferation. Notice you have 1, 2, 3, all next to each other. They're proliferating. See that? Proliferation, zone of proliferation. Then you got the zone of hypertrophy. So notice how the nuclei are getting bigger. The cells are getting bigger. It's like getting bigger and bigger and bigger. And they're laying down lots of this chondroid matrix. Now what happens to that? It starts getting mineralized. So notice it's starting to turn color here. Starting to change color. See it? Changing color, changing color, changing color. It's starting to change color here, becoming more like mineralized, like bone. And then finally, you got this area of, I can't remember what it says. Oh yeah, spongiosis. This is the primary spongiosis. In other words, this is the initial bone. It's the first bone. Then it's going to get remodeled and then become, over time, lamellar bone. It will become later. It will become lamellar over time. Okay, so that's the primary spongiosum, which will then get remodeled and become layered lamellar bone over time. So this is how you're going to grow. This is just going to keep making bone and gets longer, and keep making bone and keep making bone, and the bone gets longer and longer. Now for intramembranous ossification, these are the flat bones. Flat bones of the skull, the vertebrae, the wrist, the ankles. These are the bones that don't have a growth plate. It's basically deposition of bone on a pre-existing surface. So the bone just gets made on top of bone, made on top of bone, made on top of bone. That's how you make your wrist bones, your skull bones, your vertebrae. They don't have growth plates. It's just bone formed de novo. All right, this is going to play a big role later on. What if I have a disease affecting the growth plate? Well, if you affect the growth plate, you're going to affect primarily the long bones, but the skull will still be okay. the vertebrae will still be okay, the wrist will still be okay. Make sense? So if it's a growth plate problem, it's going to affect long bones primarily. Okay? Cool. And then what at puberty? At puberty, these don't grow anymore, right? They don't grow anymore. So what if I had a stimulation for growth? After puberty, like I had a growth hormone producing tumor. Well, that growth hormone through insulin-like growth factor is going to stimulate bone growth, but the long bones can't grow anymore. You can't become a giant. You'll only get big skull, big vertebrae, big wrist, big ankle. You get acromegaly. You get acromegaly, the extremities, and the skull deformities, right? We talked about. So very important to know the different types of bone formation. All right, now composition of bone. What is bone actually made of? Well, it's got two components. What's called an inorganic matrix and organic matrix. I feel like Keanu Reeves about to enter the matrix again. Okay, for inorganic, this accounts for 65% of the total bone matrix. Most of the bone is made of crystalline hydroxyapatite. So it's basically calcium and phosphate. That's what makes the bones really hard. All this calcium phosphate, really, really hard bone. So most of it, 65%, is made of calcium. And it's inorganic, it's not cells. Then we have the organic matrix, which is called osteoid. This makes up 35% of the bone matrix. So osteoid has to get calcified, then you call it bone. Osteoid gets calcified, you call it bone. Now osteoid is mostly made of collagen type 1. So was there any disease that had problems with collagen type 1? Well, let's see. Do you remember scurvy? Scurvy? Yeah, you couldn't make hydroxylation of collagen. So you're going to get weak bones. How about Ehlers-Danlos? Ehlers-Danlos had problems with collagen synthesis. So certain types had things like kyphosis and so forth, right? Collagen was defective. All right, now in addition to collagen, we have GAGs, glycosaminoglycan. Let's see, was there any disease of GAGs where GAGs couldn't get broken down, they'd accumulate in the lysosome? Oh yeah, do you remember Spider-Man's enemy? Curling pumpkin bombs? Hurlers. That was part of mucopolysaccharidosis. Accumulate. So just remember these GAGs, they're very juicy, they're great for joints, but they're also found in bone as well, a little bit in bone, a small percentage. All right, so did hurlers, by the way, did hurlers have bone abnormalities? Were they short? Yeah. Did they have gargoyle facial features? Yeah, the bone was a little abnormal. Makes sense. Gargoyles, short gargoyles, that's what they look like, hurlers. All right, so we have inorganic and organic matrix together, that makes the bone. Now, what cells are found in bone? There's actually 3 cells found in the bone. We have osteoblasts, we have osteoclasts, and then what do you call it when an osteoblast gets trapped inside the matrix? You call it neo, trapped inside the, no. You call it an osteocyte. Yeah, you just got trapped. It's an osteoblast that got trapped in the matrix, just got left behind, and they're gonna stay there and they're gonna basically regulate the matrix. They'll regulate the matrix. So they'll release calcium from inside the bone. Very cool. All right, now we have what's called a relationship here. We've got osteoblasts and osteoclasts having a relationship. Now, I like to run like this. The osteoblast, well, here it is, nice cell, nice nucleus. Its job is to make bone. So I remember the osteoblast, well, let's see who makes things. That's like a woman. An osteoblast is like a woman. It's like a woman because they're nurturing, they're loving, they create stuff, right? They create stuff. Now, this is a silly illustration because it's never cut and dry like this. But women are more nurturing and they usually make stuff. So she's going to make the bone. Now, to make bone, I need alkaline environments. To precipitate, basic environments are where calcium and phosphate will precipitate. So she needs to have alkaline phosphatase, and that's a good marker of her activity. If alk phos goes up, remember that could be bone disease or biliary disease. Bone and biliary both produce alk phos. Now, since it also goes up with biliary disease, another marker of her activity that's even better would be serum osteopontin. Another name for it is osteocalcin. So this is a really good marker because it is very sensitive and specific. See, alk phos is a good marker, but biliary diseases make it go up too. You have to check the GBT. So, 2 markers. The best marker for activity of osteoblast is elevated osteopontin level. But you can use alk phos as well. Alk phos going up with a normal GGT to rule out a biliary source, that'll work too. But again, we have 2 markers that can use for her activity. Now, she's the one who controls things. She has receptors for PTH, erythrohormone. Remember, if calcium is low, you're going to make PTH to bring calcium up. You want to break the bone down a little bit. Well, PTH is going to go to her. So wait a second. She doesn't break, she makes. She makes osteoid. So here's the osteoid, and this is going to become bone. When it gets calcified, you get some gags and stuff. She's going to make this osteoid, which becomes bone when it calcifies. All right, but how does she get the man to actually break it? Well, men are osteoclasts. Men smash. Men break. They break things. That's what they do. They break stuff. So notice they hanging out with their buddies, right? They're always hanging out with their buddies. Hey man, how you doing? I'm doing good. You doing good? Yeah. Let's play some games. Let's play some sports. Yeah. So these are called multinucleated osteoclasts. Now they're going to break the bone, and they're going to break it by making acid environments. So they have a proton pump, and they'll actually pump out acid, and then they'll release their lysosomes. Remember, the acid hydrolysis in there. It's going to release their lysosomal contents, which has these acid proteases. They call them matrix metalloproteinases. Matrix metalloproteinases that will break down the bone. By the way, I don't want to release this acid everywhere. So this osteoclast is going to bind to the bone. So here's the bone. It's going to bind to it and create what's called a Hauschiff's lacunae, a little hole where it's going to throw all this acid and lysosomal enzymes into, and this will start digesting this bone. And when you digest the bone, you can release the calcium and the phosphate from the bone. Calcium phosphate. And you can release it out. Now, how does the woman tell the man, because she's in charge of this relationship, how does she tell the man, hey, get off the couch and go smash something. Come on, go to work already, do your job. How does she do it? Well, PTH binds to the receptor, and then she will turn him on by exposing her rank ligands. Now, this is kind of a naughty way to do it, but this is rank ligand. Rank ligand. Rank L. Rank ligand. Now, I drew it like boobs, right? So she shows her boobs, and that's going to turn him on. Now, he's got receptors for this, right, gentlemen? We have receptors. We're going to make them into hands. Those are our receptors. And now I'll give it to my and say, okay, now I'll break down the bone. You show me the bone. All right, now, yeah, this is called the rank receptor. Again, I'm making it silly just so we can remember it. Okay? So the woman is in charge of the relationship. She tells him, all right, it's time, do your job. Break down the bone, release calcium, let's get calcium back to bone. Make sense? Okay? So osteoblasts have rank ligand, and they also have monocyte stimulating factor. Why? Because where does the osteoclast come from? The couch. Yeah, exactly. He starts out as an osteoclastic precursor cell. Precursor is not ready to work yet. So she has to stimulate monocytes, because they're really monocyte derived. A bunch of monocytes fuse together, and then they become a giant cell. So she needs to actually turn on the monocytes, get them to fuse, and then turn them on and get them to break the bone down. Okay, so very important to remember, osteoclasts derived from monocytes. So she needs to call them in and get them to fuse together with their buddies. Okay, now what do osteoclasts contain? They got acid phosphatase and lysosomal acid proteases. They're going to destroy the bone in what's called Hauschiff's lacunae. These lacunar spaces are basically resorption pits. See, I don't want these enzymes and acid to go everywhere, so I'm going to have adhesion over here, hold on to the bone, and then throw all this into this pit and let it reabsorb from this pit. Now, markers of osteoclasts are CD68. This is a pan macrophage marker. All macrophages have 68. Remember, this comes from monocytes. These are macrophages, really. They also have CD61, glycoprotein 3A. Now, wait a second. Was there a disease where that was missing? Was there a disease where 2B3A was missing? 2B3A, but not on your macrophages, on your giant cells? Yeah, very good. 2B3A, 2B3A. Bernard-Soulet or Glanzmann's? Well, this was Glanzmann's. It's okay. I was getting confused too. Remember, Bernard-Soulet, 1B. What starts with 1B? Bernard-Soulet. It's okay. I was getting confused too. So Glanzmann's was missing 2B3A. 2B3A, Glanzmann's brother's. It's okay. It's all good. All right, so this is another marker that's found not only here, but it's also found on platelets. It's also found on your multinucleated multinucleated, what makes the platelets? The megakaryocyte, thank you. These are megakaryocytes as well. So megakaryocytes, platelets, and they're also on these osteoclast-like giant cells too. All right, so let me just show you this relationship, because she makes the bone, then he's got to break it. There always has to be remodeling. If I just build the house once and I never do anything to it, it's eventually going to fall down. You got to remodel and remodel and remodel. So every once in a while she says, okay, get off the couch, break it down, and now I'll rebuild it better. I'll make it better than it was before. So every 5 to 10 years, every molecule in your skeleton has been remodeled. Every 5 to 10 years. So that means when your mother says, you know, you're not the same person you were 10 years ago, she ain't kidding. You got a whole new skeleton every 10 years. You got everything replaced. So to have strong bones, you got to constantly model. So this relationship is important. She's going to make it. He's going to break it. When he breaks it, she remakes it and breaks it, remakes it. This is beautiful. This is the relationship that we need to be in. Give and take, give and take. Both parties are necessary. If he doesn't break the bone down, well, you're going to have bones that are going to get thicker and thicker and they're going to fracture. If she doesn't make bone, well, then your bone's going to get thinner and thinner and you're going to fracture. You have a give and take. Equal parties, equal relationships. This is beautiful. This is what the body does. Equal relationships. Now, here's an example of this equal relationship. She is making all this bone. This is osteoid that will become darker as it starts to get calcified. And then here are these multinucleated giant cells. These are your osteoclasts that are breaking the bones with their little resorption pits. See these pits here? Where they put in the hydrogen. They release the hydrogen into here. These are house ships lacunae. Okay, so she's making it, he's breaking it. Teamwork, teamwork. All right, so look, here they are, a bunch of osteoblasts. Yeah, this is the girls getting together. Hi, girls, did you see the thing? Oh, yeah, me too, yeah. They're all hanging out, just talking about the day's events, and they're producing osteoid. Beautiful, beautiful, beautiful. Now over here, these are the guys at the bar. Hey, come on, buddy, let's go to the bar. We're at the bar here. Okay, come on, let's serve up some of this drink, right? Just start drinking, breaking the bones down until it comes up to here. Oh, hi there. Hi there, young lady. What do you do? What's a young, beautiful osteocyte doing in a matrix like this? How you doing? How you doing? So they're at the bar, breaking down the bone until they come across a lady. Then they'll free her. And she just got trapped in behind, and she's regulating the these are the osteocytes. So osteoblasts make it, osteocytes regulate it, and then of course we got the osteoclasts who break it down. For a beautiful relationship. Okay, feel good? Anything that messes up this remodeling is going to cause weak bones. All right, now here's an illustration of what I just drew for you, done professionally without booze. Okay, here's the osteoblast, also known as a stromal cell. Here is the osteoclast precursor that has to be differentiated into osteoclast in order for him to bind here, make nice little tight connections, and then make this pit where it can absorb bone. All right, now here's the osteoblast. What does she need to do? She has to give him monocyte stimulating factor, colony stimulating factor. This will turn him on, make him fuse with his buddies, and become a giant cell. So she needs to make sure that she keeps these cells coming in and fusing with their friends. Then she has to turn them on and tell them to do their job. She does it with the rank ligand binding to the rank receptor. Now we call it rank because it's a receptor activating of nuclear factor kappa B. So this receptor here, rank receptor, is going to activate these nuclear factors which turn him on. And he'll start making proton pumps, it'll start releasing acid hydrolases and acid proteases, and he'll start doing his job. That's how you get the signal into the nucleus to tell him to do stuff. Now question, ladies, do you want to turn your man on all the time? No. There's gotta be some breaks, man. You can't have a guy all the time working. You want to break it down from time to time, get jiggy every once in a while, but not all the time. So you need to wear a bra. You gotta wear a bra. You don't turn them on all the time. So what is this bra that covers up your ligands here? Well, it gets a very important name. This is called osteoprotegrin. Osteoprotegrin. What it does, it blocks the rank ligand interaction, and therefore keeps these guys quiescent. So that way they don't break down the bone, because if they break it down all the time, then you can smash stuff quicker than you can build stuff. You can smash stuff quicker than you can build stuff. So if we kept them turned on all the time, continuously, your bone would liquefy. So we want to turn them on from time to time, but not all the time. So wear a bra occasionally, and then turn them on occasionally. So this is going to regulate, okay? So this osteoprotegrin protects the bone from reabsorption. It protects the bone from reabsorption. Make sense? Okay, very good. So very good to cover up this white ligand. Now later on, we're going to see a drug, a monoclonal antibody against the rank ligand. So that makes sense. If I make antibodies and I block it, it's like putting my bra back on. It's like covering it up with antibodies, and it will stop this signaling from occurring. So that's going to be called disumab. We'll see it later on the notes. We're going to use this for cases of osteoporosis, where the bone is just breaking down too fast. We'll give them this MABs, these monoclonal antibodies, that will cover up the rank ligand. It'll act like osteoprotegrin, and it will protect our bones from further breakdown. Just a monoclonal antibody against the rank ligand. So remember this. We'll see if this is some. I think I'm missing a letter, but anyway, we'll see. My spelling is always terrible. Anyway, we'll see the spelling coming out. Okay. There it is, denosumab. I knew I'm missing something. No, I was missing something. There we go. Denosumab. There you go. Denosumab. Thank you, Sam. Spelling. Denosumab. That's it. So that's a very cool drug. We're using it for a couple of things now. We're using it for a tumor where you have giant cells occurring because you have a tumor cell producing a lot of rank ligand. So we can stop that tumor by giving antibodies against rank ligand. That's going to be called a giant cell tumor bone. And we're also going to use it for osteoporosis. And that's a big use nowadays. Very sexy drug to use for osteoporosis. Cool. You Googled it for, bravo. I thought you just knew it. Wow. I'm impressed. Well, we'll be on the exam. All right, now we get to pathology. Now that we've done all the foundations, we hinted at pathology, and now we get to do some really cool diseases. And I really like these bone diseases. They're so interesting. So we're going to start with some of the congenital disorders of bone and cartilage, and there's only 3 of them. We have achondroplasia, osteogenesis imperfecta, and osteopetrosis. Out of the 3, they're all asked, but the most commonly asked is achondroplasia. So we'll start with that, but they're all asked, all of them. Now, A means without, chondro means cartilage, growth, without cartilage growth. Why isn't the cartilage growing? Remember, cartilage are important for growth plates? Well, this is going to be the most common cause of short stature dwarfism. You're going to be a dwarf here because your long bones won't grow. Remember, long bones need a growth plate. So you're going to be really short stature. In fact, whenever you watch a movie, do you remember, follow the yellow brick road, follow the yellow brick road, follow This is a whole cohort of achondroplasia. All of them have achondroplasia, short stature. And then, of course, do you know the mini-me? Mini-me is a special form of achondroplasia. It's very short stature. Bowing of the lower extremity is very common, by the way. And of course, the one that your generation knows best is going to be, oh, not this one, this is too young for you. This is Hervé Villechaize from Fantasy Island in the 70s. The plane. He was also a James Bond villain. One of the James Bond movies with Roger Moore, Man with the Golden Gun. All right, your generation won't know that, but do you know who did his autopsy? He was 11. His autopsy. But this is the one your generation knows. Tyrion Lannister. A Lannister always pays his debts. Yeah, see, real short. The imp, right? The pimp. You know, he's got the curvature, very curved. Now, notice the body is normal body size. The head is normal size. It's just the extremities are really short. That's the problem with achondroplasia, really short extremities. Okay, so let me go back here. Now, let's talk about the genetics. This is an autosomal dominant, so chance of giving it to your kids? 50% chance. And wait a second, 50% chance. And do you think one short stature individual might marry another short stature because they kind of see eye to eye? Yeah. So this is very important. You need genetic counseling and genetic screening, especially if both marry each other. Their chance of having a child is very, very high. Even if they marry a normal sized person, there's a 50% chance that children are going to have this. So genetic counseling and genetic screening are very important. What was that show? Little world, no, little people, big world, no, big world, little people, something like that. Anyway, there were two short stature individuals. Luckily, they had two different genetic diseases. One is achondroplasia, I forget what the other one has, but they're not the same disease. They still have 50% chance of giving it to their kids, but they also adopted, because this is very sad. Not every case does the parents have it. In fact, most mutations are new mutations. So can you imagine you're normal, she's normal, and then your kid's short? Do you think these kids are given away for adoption? Yeah, so they actually adopted a couple of kids who had short stature because they're like, well, we understand what it's like. We'll come live with us. It's all good. You're good. Look, we're doing great. You're doing great too. Wow, that is so cool. Very cool. So again, most of these mutations are new ones. So normal-sized people could have kids with achondroplasia. And then if you have achondroplasia, you have 50% chance of passing on. Now, here's the contestant exam. A lot of mutations knock stuff out. This is a gain of function mutation in the fibroblast growth factor receptor number 3. We're going to see this a couple of times in this chapter. Fibroblast growth factor receptor number 3 gene gets turned on. Now, think about that. You turned on fibroblast growth factor receptors? Do you think fibroblasts are going to grow? Do you think they're going to lay down fibrosis in your growth plate? No. You have fibrosis in my growth plate. That growth plate is going to fuse too early. So that fibrosis inhibits the proliferation of function of chondrocytes at the growth plates. And therefore the growth plates ossify. They fuse too early. So now you have a short, long bones. The skull bones are okay because they don't grow from growth plates, but you have long bones that are short. And again, 90% are new mutations, usually occurring in the paternal allele. So this time you can blame your dad. You can blame your dad for this one. So the new mutations usually occur in the paternal allele. So blame your parents. Always blame your parents anyway, but this time you can really blame your parents. Now, for clinical, they're going to have short extremities. They often have bowing of the leg. Their head is relatively large compared to their size. It's relatively large. They often have frontal bossing. So next time when Game of Thrones come back on, notice his forehead is very rounded, very prominent, rounded forehead. That's frontal bossing. Now, intelligence, beautiful. Are you kidding? He's playing that game better than anybody else. He might win the Game of Thrones. He was, let's see, he was a consult to the king, right? He was the hand of the king. And now it looks like he may be Hand of a Dragon Queen. So he may win the Game of Thrones. And by the way, I stopped rooting for good guys. In Game of Thrones, I'm only rooting for bad guys now. Because every time I root for somebody good, they kill them. So now I'm rooting for the worst people. They always ruin the ones I like. So now I'm going to root for only the bad guys. So maybe I'll still kill the one good one. Just the way it is. So intelligence, fine. Ability to have kids, fine. Fine, better do genetic counseling. Lifespan, normal, unless you're killed or attempted to be killed by your own father tries to kill his own father. Wanted to kill him. Oh, by the way, in the action movie, the TV show, I should say, the TV show, they totally blew it. Do you remember they said, when we came to see you, you were deformed. No. You're not, when the baby's born, are you going to notice their long bones are short? No. When they're born, the kids look fine. Then as they grow, the long bones don't grow. The chest grows, the vertebrae grows, the skull grows, but not if that's when you start becoming deformed. So I guess they did it because the writer is not a doctor. It's not a doctor, but yeah, they're not deformed when they're born. They're not monsters when they're born. All right, now let's talk about a rare variant that is lethal. Thalanophoric dwarfism. Now, this actually means death-loving. Yeah, phoric is love, thalana is death, death-loving dwarfism, because they're gonna die. Very bad. This is a most common lethal form of dwarfism. You're gonna die. Now, this is again a new gain of function in the same exact gene, but it's a different mutation. It's a worse mutation. So these patients tend to have very short limbs, again, frontal bossing. But the problem here is the thorax is too small. It's too small. There's no room for the heart and lungs. No room, so the lungs get crushed. And as the kid tries to, he can't grow, and they die a respiratory death. Isn't that terrible? So these are dwarfs that are going to die because they can't breathe after a while. The chest does not grow. It's not good. So thalanophoric is just a very severe form of achondroplasia. And there's other forms too. There's forms where the hands can be big or small. There's heads are big and small. There's different variants. In fact, Hervé Villechaize, he had a variant that had throat problems. So if you remember Hervé Villechaize, the one from James Bond, Man with the Golden Gun, he was like, Dublin, because he had all these vocal respiratory problems. That's Hervé Villechaize. That's this guy here, this one right here, Hervé Villechaize. So he had a variant, they're going to call his variant the tattoo variant because of the vocal problems. All right, so very high yield, remember, gain of function, fibroblast growth factor, you fibrose your growth plates. Now let's read this one. Osteo means bone, genesis means formation. Bone formation is imperfect. Oh, we don't make the bones properly. So this is a group of diseases caused by defective synthesis in type 1 collagen. Oh, remember most of the part of the matrix was made of collagen, right? The organic matrix. So unfortunately, without collagen type 1 being made properly, your bones are going to be very weak, and you're going to get thousands of fractures because your bone is weak. You're going to get deformities and fractures. Okay, so again, collagen 1, it's actually the precursor, the pro-collagen 1 that's actually defective. Now the genetics here is again, it's a dominant mutation in most cases, although there are some other forms as well. But the most common is a dominant mutation in collagen 1, the A1, or collagen 1, the A2 subunit. So again, it's collagen 1 subunit mutations, collagen 1. Now this is mutation in the coding sequence for the alpha 1 or alpha 2 chains of type 1 pro-collagen. See, it's the precursor that's defective. So I can't make good collagen 1 if I'm not a good precursor of subunits. Makes sense? Now, this is one of the rare times they can ask about not only dominant, but dominant negative mutations. Dominant negative mutations. That's cool. That's sexy. Dominant negative. Now, dominant, it's also dominant. What is negative? It means the misfolded, damaged type 1 pro-collagen is going to bind to the normal, because remember, you have two genes. Dominant means one gene is mutated, one gene's normal. So the mutated protein, procollagen 1, is going to bind to the normal procollagen 1 and knock out all the collagen 1. They're all going to be abnormal now. Even the normal gene was now affected. So we call that a dominant mutation with a negative protein effect. The mutated procollagen protein knocked out the normal procollagen protein, so now your collagen 1's really affected. Really bad bones. Now they call these China dolls. Why China dolls? Because you grab them, you pull them, you fracture them. They're like China. You break them. So there's not enough bone, and they fracture like crazy. You're going to see thousands of fractures, and when they heal, you're going to get deformities. When they heal, the fractured bone heals, you get deformed. Fractures and deformities. Now, what is this going to sound like if I grab a kid and I fracture them, and then when you bring them in, you actually see there's older fractures of various ages. What are you going to say when you see a child with fractures of various ages? You're going to say, what do you do with this kid fractures? Will you punch it? Will you beat it? This is often confused with child abuse. You're going to call it Child Protective Agency. Seriously, in real life, this looks a lot like child abuse. Now, one clue is when you're shaking a baby, you're going to see retinal hemorrhages. So you're going to look for retinal hemorrhages. What are you beating this kid? When you're shaking it, let's look for retinal hemorrhages. When you look, you'll see blue sclera instead. Because the collagen in your white part of your eye, it should be white. It's going to look blue. It's going to look blue because it's so thin. Light goes through the collagen of your sclera, bounce off the veins of the choroid plexus, the choroidal veins, bounces back. When it bounces back, it looks blue. So your whites of your eye will look blue hue, blue hue. If you don't believe me, look at your forearm. You see your veins? See they're kind of bluish purple? They're kind of bluish purple. Oh, you can't really see that. They're like blue purple. So if you look at your veins, this is the same concept. Light's going through the same collagen, bounce off the vein, coming back. It kind of looks bluish green. That's what this sclera looks like. Blue sclera. That's it. When you see that, you say, okay, please call back Child Protective Agency and say, sorry, we made a mistake. This is a genetic disease. So look for that blue sclera. It's a very important clue. By the way, another person who can get blue sclera, sometimes you'll see it in Marfan's, and you'll see on people on chronic steroids. Chronic steroids because you don't make collagen properly. Remember Cushing's? You don't make collagen properly. You get very thin sclera. Okay, so again, blue sclera is not 100% unique. But when I hear it, I think osteogenesis imperfecta first. That's the first thing I always think of whenever I see blue sclera. But you can see it with Marfan sometimes, and you can see it also with chronic steroids. All right, now where else do you have collagen 1? Not just in your, you got it in your teeth, your dentin. So they're going to get what's called dentinogenesis imperfecta. Their teeth are going to be small, misshapen, yellow, cavity-ridden, yellow, full of cavities. They're going to break down. Yellow, cavity-ridden teeth full of cavities. Now, what about the bones in the ear? They're going to fracture too. Remember the middle ear? The inner and middle ear, you got those bones in there, and they're going to fracture too. When they fracture, you can't hear. You're going to get conduction defects. You're going to have trouble with hearing. So hearing loss is going to occur. Okay? Now, what about bruising? Do you have collagen in your skin? Yeah, easy bruising. So again, this could easily look like child abuse when you see fractures and easy bruising. Okay? All right, so here's my crazy mnemonic for this one. Ready? Osteogenesis imperfecta, OI. Watch. Osteogenesis, O-I, imperfecta. Does that not look like a kid standing there? Doesn't look like a kid? Now you grab his arm, you pull it, fracture. You broke his arm, you just fractured it. Grab his leg, oh, that fractured too. Grab his other leg, oh, that fractured. Grab his arm, oh, you fractured him. They get thousands of fractures. Now, can anybody tell me what number Roman numeral is this? What Roman numeral number is this? Oh, that's 1. To remind me, it's the procollagen 1. Procollagen number 1. Procollagen 1 mutations. All right, now what else are you going to have? Well, the ears. The bones in the ear are going to fracture. What'd you say? I can't hear you. He needs a megaphone. He's not old. No, he's not old. He's not Canadian. No, he can't hear because he's got hearing problems. Now his teeth make him yellow, broken, fragmented, cavity-ridden teeth. Oh, this poor dude looks like a hockey player now. Broken teeth. And then finally the sclera. Give him blue sclera. Now I don't have blue, so just pretend this is blue. Blue sclera. Wow, isn't this a masterpiece? It's a masterpiece. Everything you need is right there. That's beautiful. Imagine if your parents said, let me see what value you're getting from Indiana University Medical School. Let me see, we're paying a lot of money, let's see. But that's everything you need right there. You look like a poor, terrible child. So that's everything you need there for osteogenesis imperfecta. You might remember that. Osteogenesis imperfecta. The I is like collagen 1. It's like a 1. It's like a number 1. Now I'll show you some pictures of it because this is a classic disease. Look at this poor kid. Doesn't she look deformed? Doesn't she look, you grab her on the fractures. Look at this. She's had so many fractures, it's now curved. She's deformed. Look at her face. She had fractures in her face. Her face is all deformed. You get lots and lots of fractures here. Now let's x-ray this arm. Let's see why it's so curved. Oh yeah. You probably had a fracture here. Probably one was here. Probably one was here. And when they heal like this, they get all deformed. They get all these deformities. So thousands of fractures. Now here's the classic picture on the exam. Now of course, your computer screen is the colors are gonna be off. And you're like, it's blue hue. It's not bright blue, it's a slight blue. So a slight bluish hue. I would agree that these are kind of bluish. Now again, if your Prometrics Exam Center's computer may be slightly off, but if they're looking up, they're trying to show me something here. They're trying to show me this is slightly blue. You have to use your imagination on some exams. So look for that blue sclera. Very important clue to tell me it's not child abuse. Getting fractures because of a genetic disease. All right, now do you remember the Bruce Willis movie, Unbreakable? Bruce was unbreakable, and then his enemy was Samuel L. Jackson. Well, they called him Mr. Glass because he had osteogenesis imperfecta. He fell downstairs and he got thousands of fractures. Now, they kind of blew it in the movie. Hearing, perfect. Eyes, perfect. Teeth, movie star, perfect. I guess it wouldn't have been a good movie. He couldn't hear. But at least give him some bad teeth. At least give him some blue sclera. What explains it is the person who wrote this was not a doctor. Yeah, but or maybe they just Googled it and saw that there's a disease with thousands of fractures. But there are variants, though. Some variants don't have blue sclera. Some variants don't have bad teeth. So I guess it's acceptable. It's acceptable. But more likely the person who wrote it just didn't know. M. What's his name? Shalama? M. Night Shyamalan. I can't pronounce it. But anyway, his wife, I think, was a medical student or physician. She thought of the idea for him. All right, now I just put this table in here to show you there are different types of osteogenesis imperfecta. But I'm immediately going to cross it out because I don't want you to memorize it. I know if I put it in front of you, you're going to try to memorize it. No, but what did I just do? Just first, messed up everything. Hold on. I tried to cross it out and I changed the screen. Hold on. Let's see if I can fix this. All right, I fixed it. All right, I'm going to cross it out because as soon as I give you something, you're going to try to memorize it. No, I don't want you to memorize it. I just want to show you that they're mostly dominant, but there are some recessive forms. Recessive forms are more severe. So if you only want to know one thing, type 2 is the worst one because it's recessive. They're so fragile. What happens during labor? And they squeeze out as a broken, crumpled pile of bones. They die during labor. So type 2 is the worst one. It's recessive, it's very severe, and they usually die during labor. But again, forget that. I do not want you to memorize, hey, what is type 1, no. Just I want to show you, some of them have little progression, at puberty they stop, some have blue sclera initially, then they turn white, they have bad teeth, some don't have bad teeth, So it's quite variable, there's different subtypes. Do not cross it out, don't memorize it. Just wanted to show you that the recessive one is the bad one. That's all I was trying to show you here. And I think in the movie, Samuel goes, I got the worst type of osteogenesis imperfecta. No, you don't. You're still alive. Type 2 is the worst. They die during delivery. In fact, the only way these babies would ever survive is if you knew about it ahead of time and you did a C-section. Like, do a C-section. If you don't do a C-section, you're going to die from the actual labor. Terrible, terrible, terrible. All right, now what about this one? This is our third of our congenital problems. It's called osteo, which means bone. And then we got petrosis. Well, let's see. Petrified wood, that's wood that turns to stone. Yep, these are bones that turn to stone. Petro means stone. So osteopetrosis is stone, bones that are stone. So another name is marble bone disease, because your bones are thick like stone, like marble. An older name is Albert-Schoenberg disease. Those are the people who described it. So I'm just putting it here for completeness. It's referred to as osteopetrosis, but it's often referred to as marble bone disease. Now, there's again a group of diseases with different inheritance. Group of genetic diseases. The problem they have together is there's a defect in the osteoclast bone resorption. Oh, if the guy don't get off the couch and break down the bones will get thicker and thicker and thicker and thicker and thicker, and you'll get bones that are like stone. Isn't that good though? No. If you don't remodel them, even though they get thick, they break. I want you to think of this like chalk. Chalk. If you feel chalk, it feels firm. It feels firm. And then it fractures like that. It's firm, but it fractures because you're not remodeling it. These bones are like chalk. They're dense, but they fracture easily. Okay, so dense, stone-like bones that become weak and they fracture like chalk. Okay, so they're dense like chalk, but they fracture easily. Because remodeling, you're not remodeling them. All right, now for the genetics, there are different forms. We've got the dominant form, which dominant diseases have only one mutation, so it presents later and it's more milder. We have the recessive form. That means you have two mutations. Recessive, you have to have two mutations. No normal genes. So they present very severely, very early, and it's usually severe and lethal. So it's the infants who die. And then, of course, we have one more. We have one more type, and that is problems with the actual function. So we can have a problem with the proton pump, so mutations where the proton pump doesn't work, or we have a mutation where you can't make protons. You can't make protons to pump them. This is called carbonic anhydrase type 2 deficiency, which is going to be recessive because it's an enzyme. Well, for this one, you need carbonic anhydrase to make protons. If you can't make protons, well then I have the osteoclast, but they can't make acid to destroy the bone. So you're going to get thick bones. They can't make acid to excrete it in the kidney. If the kidney doesn't excrete acid, you're going to get acidosis. We call it tubular acidosis. So renal tubular acidosis, RTA for short. Renal tubular acidosis, because the proximal tubule cells can't excrete hydrogen. We can't make it. Can't make protons. And then you tend to get calcification of the brain. The exact mechanism, we're not sure. But again, wherever you have basic environments, if you can't make protons, you're going to have a basic environment, and that's where calcium deposits. So again, this type is kind of interesting because they get not only thick bones, but they get acidosis because the kidney ain't working, and they get cerebral calcification. So that's kind of something that they may want to test here. And then one more, we can have defects in maturation of osteoclasts where maybe you don't have monocyte colony stimulating factor. Well, if you don't have this, your monocytes don't work. These don't work. So therefore your monocytes will grow, don't work. All right, so those are the different forms. Notice everything is a problem with making osteoclasts or osteoclast function. Now, just to remind ourselves, here's what you're supposed to have. Here's a multinucleated osteoclast. Notice with the adhesion molecules, it makes a tight connection with the bone, grabs on really strong with these integrins to hold on, and then it creates this resorption pit. This resorption pit, what it does is it's going to take ATP, and then take hydrogen and pump it into this area. Now, to make the hydrogen, we need carbonic anhydrase. We needed to take carbon dioxide and oxygen and convert it to protons at my guard. That's what we need it for. So if I can't do this conversion, I can't make protons, I can't make acid. So if the pump is mutated, that's one form. If you're missing this enzyme, that's another form. That's another form. You won't be able to make hydrogen, so you can't make this. Now, in addition to pumping hydrogen out here, you're also going to pump chloride. Oh, now I got, okay, hydrogen chloride. Okay, that's good. Nice for breaking down bone. And then what else? We're going to lysosomes. We're going to secrete our lysosomes, all those acid hydrolases, acid proteases. And you're going to secrete lots of metalloproteinases as well. So all this is going to be digested, but the problem is these two only work if it's acid environment. So if you don't have the proton pump or you don't have the proton synthesis, you're not going to work these enzymes. They don't work without acid. So you won't be able to break down your bone. Make sense? Yeah, petrified. Yeah, wasn't that like a Patronus spell? The Patronus spell and you turn to stone? No, Patronus spell was to get rid of the Dementors. No. Shucks. Okay. Oh, petrified. Oh, the basilisk. Yeah, the eyes would petrify you. There you go. Harry Potter, you get petrified from the eye. There you go. You can't look at it, right? Very good. You can't look at it, right. I like it. I'm a Harry Potter fan, too. I was like, the Patronus spell. Yeah, that would be great. Oh, no, that's really good. All right, now, here is your key to diagnosis. There is no other disease that has generalized sclerotic bones. There's some diseases where a couple of bones get dense, but all your bones are thick and dense. Diagnostic. So get some x-rays and look at how dark these bones are, man. These are really dense bones. And then where are they the most dense? At the end, where they get wider. Do you remember the metaphyseal region? It was supposed to go like this, right? I'm going to draw it upside down. Go this way. Bone's supposed to be diaphysis, then you get the metaphysis, and then you get the epiphysis. Well, what happens here is the bones get very dense, very thick and dense, make it real dense. And then you get really big widening here at the metaphyseal region. So they often say the end of the bone reminds you, see the way it flares out here, flares out there? It reminds you of one of these Erlenmeyer-Flass that you see in the laboratory. So we call this an Erlenmeyer-Flass deformity, very wide metaphysis. So again, these x-rays are diagnostic. You see generalized sclerosis with Erlenmeyer-Flass deformities, you own it. Now, whenever there's a buzzword, they can use it for something else. So we saw Erlenmeyer-Flass deformities already. If you go in the Wayback Machine, we saw it with a lytic disease. Lytic, the bones were really light, they were lytic, but you had this deformity because the macrophages, they were eating the bone. This was called Gaucher cells. The Gaucher cells were eating the bone, so it gets very lytic, and then it gets very wide like this. So when you see Erlenmeyer-Flass deformity, if it's dense, osteopetrosis. If it's lytic, Gaucher. Remember, they both get fractures. This one because it's lytic, you get deformity fracture. This one because it's so dense, it's not remodeling. So it's like chalk, it fractures and get deformities. Fractures and deformities. So again, two things for the Erlenmeyer-Flass deformity. When I see that buzzword, think osteopetrosis first because it's in Robbins, but also Gaucher's gets a very similar deformity as well. Now let's go to the clinical here. Dense, thick bones, fracture. They break. You're going to get multiple fractures. Now, another important thing is as the bone gets thicker and thicker and thicker, do you remember the cranial nerves have to leave the skull through foramen? You remember in anatomy where they had to look at the base of the skull and they would label all the foramen and you had to tell them what cranial nerve? I hated that in my med school. I always had to look down at the skull and they had these little tag there and then the guy before me would move it, so I would be looking at the wrong thing anyway. And I have to tell what cranial nerve went through. Oh, I hear that. But needless to say, our cranial nerves go through vertebral foramen. So if this bony foramen gets thicker and thicker, it will crush the cranial nerves. And you'll get cranial nerve palsies. For instance, you go blind, you get deaf, you get a facial palsies, facial nerve, facial palsies. Yeah, so that's pretty cool. So not only do you get fractures like you did in the last case, but you also get cranial nerve palsy. It's interesting. They can also get hydrocephalus if the bones of the skull get thicker. You can compress some of the CS out. But here's an interesting one. What happens in the cavity? Do you remember the marrow cavity inside? Well, as the bones get thicker and thicker, and it crushes it, it pushes the marrow out. It pushes them out. We give this a fancy name. We call it a myelofistic process. Myelofistic. The marrow is supposed to be in here, but it gets pushed out by the thick bone. Myelofistic. Myelofistic process. That's the term for any process that pushes the marrow out. Now, question: where's the marrow going to go? Well, it's got to go somewhere. So it goes to your spleen. So you're going to get a big liver and big spleen because of extramedullary, outside of the marrow, hematopoiesis. You're going to get splenomegaly and maybe the large liver too. Yeah, large liver or spleen. So myelofistic process. Question: how about myelofibrosis? Could myelofibrosis be? Yeah, that's a myelofistic process too. The fibrosis pushes the marrow out. You get a big liver, big spleen. So any disease that basically destroys the marrow cavity is going to lead to myelofistic, where the cells have to leave. Now, unfortunately, the spleen doesn't do a great job, so you have a higher risk of infection and anemia, especially in that recessive form. This is why this one here is so severe, because their marrow never gets a real chance to grow. It just gets crushed in utero. So basically, they're going to die from anemia, or from bleeding, because no platelets, or from infection, because the marrow often fails. It just doesn't have time to really develop itself. Because your spleen can make blood, but only so much, right? You really need that marrow space. So these patients die very early from bone marrow failure. Boo, don't like it when kids die. No good. All right, we're almost done. We're almost done here. Super awesome, super awesome. Where did the osteoclast come from again? Where did this guy come from? Well, do you remember he came from osteoclastic precursors, which came from macrophages, which came from monocytes, which come from your bone marrow. Yep, it's your bone marrow that makes monocytes that go into your tissue and become macrophages that fuse with their friends and become osteoclasts. So if your osteoclast is defective, it's really a bone marrow mutation. So what if I get you a stem cell transplant, get you a new marrow? The new marrow will make good osteoclasts, and this disease will be cured. So let me repeat, it's one of the rare genetic diseases we're going to cure by doing a hematopoietic bone marrow stem cell transplant. We can cure this disease. Because when those new cells come in, they'll start lysing this bone and they'll start making it normal again. They'll start doing what they're supposed to. They'll break it down. The osteoblasts are still good. So it'll remodel and become normal bone again. How cool is that? You can cure it with a bone marrow stem cell transplant. And you know they're going to ask this. They're going to ask this. That's cool. That's very cool. So remember, these cells come from monocytes. They come from your marrow. All right, perfect time to take a break. When we come back next time, we'll talk about acquired disorders of bone, things like osteoporosis. It's only the most common bone disease known to humans. So that's a very ideal one. You know, rickets and osteomalacia already. Paget's another 5-star. So 5-star, 5-star. We're going to come back for 5-star things. Okay. Again, thanks for putting up with me. I'm sorry about the technical difficulties. I can't control Adobe, but I rebooted everything. I got a new, I tried to get a new browser. I tried a new browser and it seemed to work. So whatever the ghost in the machine was, it disappeared pretty quickly. So sorry about that. I hate it when technical difficulties occur. All right, got you covered though. Thanks, Justin. All right, I'll see you guys. I'll see you on Thursday. All right, take care.